Greetings to one and all. I would like to take this opportunity to first welcome all of you to the Kalpa 2020. The Kalpavriksha as a program has been going on for the past 14 years, and this is our 14th edition. This year, it's with a new facelift, and I would like to first thank and introduce my co-program director, Namrata Sharma, who needs no introduction, but I feel that this facelift of Kalpa of 2020 was not possible without her. The next set of people that I would like to thank and introduce to all of you is the organizing secretaries, Dr. S. Soundri and Dr. Divya Ashok Kumar, whose undying efforts have not just given Kalpa a facelift this year, but also have been holding Kalpa all these years to now take it from a national leading and first of its kind training course to now a global course. So thank you, all three of you, very, very deeply. I have to thank each and every of these wonderful 29 speakers. Most of them, I must tell you, are absolutely new to Kalpavriksha. And I must thank them for agreeing to be a part of this program. It is only because of you that so many of us are better than ever clinicians across India and I'm sure even across the world. And last but not the least, I couldn't be less, my excitement couldn't be less to tell each and every one of you that we have a record registration of 2,500 people who have registered from close to 192 countries that are participating in this program and bringing us ophthalmologists all together tonight or today, this morning, this afternoon, depending on where you're logging in from. I would like Dr. Namrata Sharma to give us a few words before we hand over the baton to Dr. Soundri and Dr. Divya Ashok.
Thank you, Ashwin, and it's always a pleasure to be here at Kalpavriksha program, which has been conceived by Dr. Agarwal Group of Hospitals, Dr. Amar Agarwal and his team 14 years ago. And I think it is the mother of all postgraduate or ophthalmology resident training program has been so ever since for the past 14 years because we've seen it grow each year, and it was in fact the first program to be started on an all India level basis. And like always, Dr. Amar Agarwal has been a great visionary, and he had thought, before everybody else that this was something that was required. In the COVID era, it is being done virtually, and the advantage of that is that we have so many of you here on board. We have teachers from all the major institutes of our country, which includes LV Prasad Eye Institute, RP Center, AIMS, New Delhi, Agarwal Group of Eye Hospitals, Shankar Netralaya, Arvind Eye Hospital, PGI Chandigarh. So from all over the country, the best teachers in those particular subjects have been picked up for you, and the lectures are going to be just representative of those teachers. And all you need to do is just focus and glue on for the next 4 days onto this Kalpa program, and I'm sure you're really going to benefit from it. The advantage again of the virtual program is that if you're not able to see at that point in time, you can always go back, and even if you're able to see at this point in time and you want to really relook again or want to see a lecture again, then you can go back and see that lecture again. So thank you, Ashwin, for doing this. Thank you, Sondri, Divya, and Kala, who are always associated with the program. It's always a pleasure to interact with them. And thank you, Dr. Amar Agarwal, for conceiving this and getting it into this shape.
Namaste. Welcome to the 14th edition of Kalpavriksha. So it is a 4-day program. Today is day one. Day one, we are going to be concentrating on cataract and cornea. The first speaker is going to be Dr. Kaladevi Satish. She's an in-house speaker. She's a cataract surgeon. She's a glaucoma surgeon as well as a gluteal surgeon. She's a winner of Young Ophthalmologist Award, John Hanahan Award. She has won Best Prize Award from American Society of Cataract and Refractive Convention, which was held in Boston. And she's won Best Video Awards for CACXL. She has performed many live surgeries in phaco and gluteal in national and international conferences. She is an invited guest faculty for national and international conferences. She has been a trainer for phaco emulsification. So you cannot find a better person than Kala to talk to you about basics of phaco. Welcome, Dr. Kala.
Hi, everybody. Thanks, Soundri. First of all, I would like to thank Dr. Ashwin, Dr. Soundri, and Dr. Divya and Dr. Namrata for giving me this opportunity. Teaching students is a passion. What you have learned, we try to advocate them. And teaching phaco basics is one of my passion, because understanding the mission is the first concept. Later, you can go and understand the procedure also. So I'll share the screen. So first, the basic talk of this session will be on the phaco-dynamics part. Before going to it, I would like to first understand the phaco mission or parts of the phaco mission. So here I show you this is the phaco mission, the eye part, and this is the foot pedal and the irrigation parts. So this is where all the mission parts are there. Okay. So the basics of phaco mission consists of fluidics and the ultrasound. So first we move on to the ultrasound part of the phaco mission. So what is an ultrasound? The phaco power, the ultrasound is the energy used to digest the nuclear material within the eye, and it is being then aspirated outside the eye. So the digestion of the nuclear pieces is by the ultrasound energy, and the aspiration part belongs to the fluidics technology. So the ultrasound energy, what is the most important concept here? The phaco power. This is expressed in percentage and is the interaction between the frequency and stroke length. So this is the most driest part of the phaco emulsification beautiful procedure. Though it is very dry, if you understand the basics, then you can go ahead very well in your phaco surgeries. So what is frequency? Frequency is the speed of the needle movement. Like you keep a needle hitting on a surface, the speed at which it moves is called as the frequency, and it is usually constant. The stroke length is the length of the needle movement, how much it moves forward and backward. So that is called as the stroke length of the phaco tip. So it is usually 2 to 6 mils. A longer stroke length indicates a greater impact, a greater power inside the eye. An increase in phaco power results in increased stroke length. So this is better controlled by the foot pedal movement. So when you raise the phaco power in the machine, say a 30% or a 40% or a 50% of phaco energy is delivered in the eye, which is actually changing, whether it is the stroke length or the frequency, the main thing which is changing is the stroke length. Frequency always remains a constant. The stroke length, how does this phaco energy work? The second question is, how does this phaco energy work? So there are various mechanisms proving us how does this phaco energy work. One is the mechanical impact. The second, the main important theory is the cavitation theory or the transient cavitation phenomenon, and the fluid and particle wave. And of course, you should know what is the heat produced. So this is a cavitation needle. You can see this phaco tip when it moves forward and backward. So when it moves backward, there is a vacuum created here. This low vacuum causes the bubbles from the fluid to come out. So it creates a micro bubbles. These micro bubbles implode upon each other to form a big wave, and a transient wave of heat energy is delivered in front. So this digests the nuclear materials. So this is why is it important is you should always know the direction of the phaco probe. So the wave is directed along the direction of the wave phaco probe. So if the phaco tip is angled, you have to direct it towards the nuclear pieces. Then is a jackhammer effect, hitting back and forth on the nucleus. Of course, when the phaco energy is increased, the heat dissipated also increases inside the eye, and this causes incision burns. So to avoid incision burns, what is a good technique which you should follow is to reduce the heat, a good fluid flow, like increase the fluid inside the eye so that the phaco tip heat reduces, and also lower your phaco power settings. Moving on to the next important questions for the postgraduate. What are phaco transducers? You all know there are two types of transducers. One is the magnetorestrictive transducers and the piezoelectric transducers. We all have moved to the piezoelectric transducer now because it produces less heat, multiple connection points, and less longevity. But the only disadvantage is less longevity. Another important terms which you hear is absolute phaco time, effective phaco time. These are certain words and technologies used in the phaco which you people have to understand. One is the absolute phaco time. It is measure of the total phaco energy delivered into the eye. Absolute phaco time is phaco time into the average phaco power. Say suppose I do a phaco with 100% power for 50 seconds, then I give 50 seconds of absolute phaco time inside. But the same can be reduced, even you can increase the timing, but the power has to be reduced. Then you deliver the same amount of energy into the eye. So you actually have to keep your phaco power less inside the eye. So what you have to do is to decrease the phaco time and decrease the average phaco power. Now, how to decrease the phaco time? Based on the modulation of the type of phaco power, what you keep, whether you can keep it in continuous mode or pulse mode or burst mode. One is the phaco continuous. What is phaco continuous? Phaco continuous is when you press down on the pedal here, the energy is delivered continuously inside the eye. So this mode is called as the continuous mode. Then we have the phaco pulse mode. This also increases in a linear frequency, but you have a 50 milliseconds of on power and a 50 milliseconds of off power. So as you press down on the foot pedal, the phaco energy increases with a split time. You have another mode called the burst mode, which is usually the best mode. The burst mode delivers a particular amount of phaco energy standardly, but the interval reduces as you go down on the foot pedal. So when you go down on the foot pedal, it fuses into a continuous mode. So this is the foot pedal depression in position 1, 2, and 3 in case of, in 3 as you push down in a phase of continuous mode. And this is a variable power which is released in a pulse mode. And this is the burst mode, variable burst interval. You can see the interval being decreased as you go at the end of the foot pedal. Now, there are certain terms in phaco technologies. What is a duty cycle? They might write 100% DC, 50% DC. So what is a duty cycle? It is the percentage of time phaco tip performs its duty. So obviously in a continuous mode where the phaco time is continuously given, you have a 100% DC. DC is on time by on time plus off time. So you can see this is a pulse mode, a 250 milliseconds of on power and 250 milliseconds of off power. So this is a 50 to 50 duty cycle time years. This is a 20 milliseconds of on power and 100 milliseconds of on power and 400 milliseconds of cooling effect. So this comes to a 20% duty cycle power. So you can vary the duty cycle power. You can, in a pulse mode, you can keep it 50% on and 50% off. Whereas in a hyper pulse or a variable pulse mode, you can actually decrease the phaco energy and increase the non-phaco energy time so that more cooling happens. So what happens during the phaco energy, the ultrasound is delivered, the jackhammer effect is there, heat is generated. What happens during the off time? You don't have heat energy generated there, no ultrasound energy. So the phaco tip cools down, the nuclear fragments are aspirated. See, the amount of energy and the heat dissipated inside the eye and the damage caused to the endothelium is definitely less when you increase the off time. So this is about the phaco power and the basics. We move on to the fluidics. So fluidics also has a certain terms like flow rate, vacuum and other stuff. What is a flow rate? Flow rate is the rate of fluid flowing outside the eye. So it helps to bring the material outside. So what happens when you keep a very low flow rate, pieces won't come to your phaco tip. So if you keep a very high flow rate, all pieces will come to your phaco tip, including your posterior capsule. So you have to have a moderate flow rate according to the machine level. Vacuum is actually the pressure difference between the atmospheric pressure and the pressure inside the aspiration tubing. It helps in holding the material to the tip and its final aspiration. It is actually a negative suction pressure which is created by the pump technologies. What is a rise time? This is very important because the rise time is how rapidly a vacuum builds when occlusion has occurred. So when a piece comes and occludes the phaco tip, how much seconds the set vacuum is built up is called as the rise time. Obviously, it is faster in Venturi than peristaltic pumps. So we always say a beginner to start with a peristaltic pump and then move on to a Venturi pump. So how do we create vacuum? So this is basically the fluid pump here, which creates the vacuum. You have three types of pump, all of you know. One is the peristaltic pump, one is the Venturi pump, and the diaphragmatic pump. This is a peristaltic pump. It consists of series rollers. You can see a series rollers rotating on one side. As the tubing passes on the rollers, it pinches off and it creates a vacuum. So you can see when a piece is getting occluded and when this roller is setting to move, the pieces are held up and slowly the vacuum is built and the pieces are being aspirated. You can see the collapsing of the tube here and the vacuum is being generated and the pieces are being aspirated. This is a Venturi pump. This is basically the passage of a compressed air, high pressure, low velocity into a low pressure, high velocity zone. So this creates a vacuum in a rigid drainage cassette and the fluid aspirates inside, works on the Bernoulli's principle. The most important postgraduate questions usually asked is what is the difference between a peristaltic pump and what is the difference between a Venturi pump? So you can note down the details. It is flow based and it is vacuum based. Vacuum is created only on the occlusion of the phaco tip. This is created instantly when the pump is on. Flow is constant until occlusion. In the flow varies with the vacuum level. It drains into a soft bag, whereas in a Venturi pump, it drains into a rigid cassette. So what happens to the fluid flow? So you know this is the equation. When you read this formula, people get fainted or they go mad, and by this chapter, the chapter gets over. But this is a nice formula. If you see, the fluidics is dependent only on, if you see, all are the constants. So pi is a constant, number is a constant, viscosity of the liquid which you use is a constant there, and the length of the tubing is already set. So in a present case scenario, the flow is always proportional to the pressure gradient and the radius of the tubing. So pressure gradient and the radius of the tubing. So radius of the tubing, there are two ways. One is the inflow tubing and another is the outflow which happens. So the inflow, the pressure gradient is controlled by the bottle height and the radius is determined by the inflow tubing size and the irrigating instrument. So this gets controlled by the air pump and other facilities to increase the flow inside the eye. And you have the bottle height which also increases the fluid. So this is the bottle height drip where the intraocular pressure changes. And second is the outflow. So the outflow of the fluid outside the eye, that is determined by the fluid pump. So how much is the aspiration rate set? What is the vacuum? And the radius of the tubing of the outflow tubing size and the needle tip size. So this is very important for the outflow and inflow. Why am I discussing this? Because most of the people who land up in a posterior capsular rupture or not, this is the problem. The surge is an important phenomena which causes problems like PCR and other stuff. What is surge? Surge is an important postgraduate questions which is usually asked constantly. When the phaco tip is occluded with the nucleus, a high vacuum is created in the outflow tubings of the elastic wall and the eyeball actually collapses. So you can see when the piece is aspirated, there is a high vacuum which is being created. So the fluid maximally rushes into the outflow tubing and the PC comes up and the cornea also flattens and the chamber collapses. So this phenomenon is called as the surge. So when will the surge happen? When your outflow is actually more than your inflow, then you get surge because your anterior chamber collapses and the risk of capsular rupture increases. What you have to do is make sure your inflow is always greater than the outflow. Then this will prevent surge. So what are the parameters which affects the inflow? One is the bottle height I told you. So increase the bottle height when you see surge. We can always use an air pump and you can have a sealed incision, which is a good incision, and the size of the tubing is also to be adjusted. So these are the points which you can adjust in the inflow. And outflow should be reduced. So outflow reduced, what you can do is the aspirated fluid, you can adjust the flow rate. And of course, the tightness of the incision also matters. So always keep your inflow more than the outflow. And this is important to prevent surge. And your outflow tubing, if you see in the phaco tube, is always much smaller than the inflow tubing. And make the outflow tubing rigid and low compliant. That is helpful in preventing the surge. Raise the bottle height, tighter the incision, restrict the outflow tubing. Now, most innovative machines like the Infinity and others, they have certain specific mechanisms inside the eye which helps to prevent surge. One is the aspiration bypass systems. You actually have aspiration tunnels in the phaco needle tip. So when the vacuum builds up, actually, the needle through this tip, the tube collapses and post-occlusion surge, the fluid goes in. In these systems like Alcon, what happens is through the hole, the fluid goes inside and the collapsing part is prevented even when the phaco-tip is occluded. In the AMO, we have certain systems like the chamber stabilization environment. They have microprocessors which sense the vacuum drop below a certain level, then the flow automatically increases, and this helps to prevent the surge. In BNL machines, we have the clogging system where the pieces don't go immediately outside. They get clogged onto the tubing and the flow slowly decreases. So we come back to the same phenomena that the flow is always proportional to the pressure gradient and the radius. Only thing which is in your hand, and when the phaco surgery goes out of control, you have to always check your inflow is always greater than your outflow. So efficient fluidics and efficient phaco power, you get a clear-cut result, and the surgery is very good with clear cornea on the other side. Apart from this, now the latest technology is femtolaser assisted cataract surgery. So I thought I would like to add few points on this for the beginners. So what does this femto surgery, surgical excellence move? They help to fine tune the precision and bring out a powerful performance inside the eye. So what does these femto laser cataracts, how do they help? One is they help us in a fine tuned incision based on the astigmatism present inside the eye. The incisions become perfect and the length and the arcuate length remains the whatever we need, it is set in the table. The second is the capsulotomies. So for a beginner, the capsulotomies are a tough challenge, and there are cases where the capsulotomies easily run, like young individuals, when the intraocular pressure inside the chamber, inside the lens increases, like in mature cataracts, fluid filled cavities and everything. So this helps in highly accurate capsulotomies. It helps to decide the size of the capsulotomy. So it is helpful in centering the IOLs, particularly for the multifocal IOL and other stuffs. And also the third important thing is the fragmentation. It actually fragments the nucleus and softens the nucleus, thereby helping us to reduce the phaco energy used within the eye. So it plays effective in lens fragmentation. It nearly eliminates the ultrasound, softens and segments and minimally retained gases, fragments volume. And so this is the procedure. You can see the nucleus being fragmented, and you can see the arcuate incisions being given, which is helpful for the astigmatism correction. This is a slide showing the incision of the phaco incision tunnel. This is the OCT view image, which you get a perfect incision, a 3-planar incision. This works on liquid optics technology. The liquid optic technology is easy because your screen length is particularly, the refractive index remains the same throughout. So this flax surgery helps us in arcuate incision. It helps us in cataract incision, basically a blunt dissection of the incision. Liquid optics is one biggest advantage. It is also associated with OCT imaging. So you can guide us through the posterior polar cataracts, whether the PC is split or not, and also helps us in using a lesser phaco power inside the eye. So this is one of the most important advantage. It helps us in an easy learning curve. The clinical results are really good. The surgeon confidence is high. Patient satisfaction is improved because of proper centration, and physician feedback is good. And so in case few years, these procedures are becoming high on high when compared to the normal phaco. So I would like to end the session saying that always be careful and start your phaco very pointedly. And the best tip which I would like to say to the students is, the secret of a successful phacoemulsification is, don't not hesitate to accept the technology. Be bold and take a plunge into the phaco basics. Understand the mission first. You have to understand the bus first to drive a bus. You have to understand the car first to drive a car. The same way, you have to understand the mission technology to do the phacoemulsification in a better way. So understand the technology, what is given there. Go slow with the patient and follow the masters. Always remember the important tips regarding your vacuum, flow rate and others. And the most important point which I would like to say is, if something is not happening in your eye, if the pieces are not coming to you, after finishing the procedures, come back and go back to your settings and understand why the piece did not come to your eye or why the PCR has happened. That will help you out. So I would like to thank everybody for giving me this opportunity. Questions and queries we can answer in the chat box. Is it Soundri?
Anybody having questions can put it in the chat box. So people can put it in the chat box and the presenters can answer to your questions. I welcome Dr. Divya Ashoka, my co-moderator. She'll be introducing Dr. Namrata Sharma.
I'm happy to introduce Dr. Namrata Sharma. Dr. Namrata Sharma did her post-graduation from Dr. Rajendra Prasad Center of Ophthalmic Sciences, AIMS, New Delhi. She did her fellowship from Moorfields Eye Hospital in London. She is a honorary General Secretary of All India Ophthalmological Society. She has been in many administrative positions, including Secretary of AOS, Secretary of Eye Bank Association of India, ex-secretary of Delhi Ophthalmological Society. She has given more than 308 publications and has authored 119 book chapters and authored 11 books, including corneal transplantation, corneal ulcer, step-by-step plastic surgery, phacoemulsification surgery, decimal stripping, automated endothelial keratoplasty, and many more. She has been a recipient of many awards and achievements. Few of them are Asia Pacific Academy of Ophthalmology Leadership Award, Senior Achievement Award from AAO, Achievement Award from Asia Pacific AAO, Best Video Award by EACRS, Best Paper Presentation, and International Ophthalmology Education Awards. And she has received many national awards, including Gold Medal from Bombay Ophthalmic Association, Colonel Rangachari Medal Award of AOS, AC Agarwal Trophy of DOS, and AIMS Excellence Research Award. I welcome you, ma'am. She'll be talking on ocular surface disease.
Thank you. Thank you so much, Divya, for that kind introduction. It is always lovely to be introduced by our own students. It is a great pleasure to be introduced by them. And Divya has been a very good student from RP Center and now doing great work in Agarwal Eye Hospital. I would be talking to you about an important uh, subject, and that is ocular surface disease. And I'm sure you must be coming across these cases, but it is also important that you know the surgeries about these cases. So this will come, ocular surface disease, any variety will come to you as a short case, or sometimes even can come to you as a long case. So I've tried to put it in pictures and figures and videos so that it stays in your memory, because I always believe whenever I teach that once you leave this classroom or you leave the teaching class, you you should have a visual impression of the same, and you should almost mug it up here only without having you to go back and read it up again. So basically, we need to know the anatomy of the eyelids, conjunctiva, cornea, limbal cells, stem cells, and the tear film. And this is important because there are a lot of conditions which have limbal stem cell deficiency. So you have limbus, which has corneal epithelial stem cells, which has basal layer of peripheral cornea and the limbal zone, the limbal palisades of Vogt, which you see here, and then limbal epithelial crypts, which actually have these limbal epithelial crypts that you have limbus, which is the junction of the cornea and the sclera. You can see those brownish, limbal palisades of Vogt, and therein lie the limbal epithelial, stem cells, and these are the stem cells which are responsible for the clarity of the cornea. So the disease of the ocular surface can be blepharitis, dry eye, pterygium, autoimmune disorders, and stem cell deficiency. And if coming to the first one, which is blepharitis, you can have anterior or posterior. So when you have anterior, you can have at the base of the eyelashes, follicles, staphylococcus. It could be due to infection like staphylococci or maybe seborrheic, or it can involve the meibomian glands, such as seen in this picture. And when it involves the meibomian glands and the orifices, then it is called as a meibomian gland disease. Sorry. Then this is the pathophysiology of the obstructive type of meibomian gland disease. Basically, there's obstruction in the meibomian glands, which leads to increased viscosity of the secretions, and there is hyperkeratinization. And this is the classification of the meibomian gland disease, which could be low delivery, high delivery, hyposecretory, or obstructive. Each of these could be primary or secondary, cicatricial or non-cicatricial. Then hypersecretory could also be seborrheic, dermatitis, and due to acne rosacea. And basically, there's alteration in the tear film with eye irritation, clinically apparent inflammation, and ocular surface disease, which includes dry eye. Now, clinically, it is good to examine such cases because when you just press on the lids, there could be even cloudy expressed medium like this, or strings of toothpaste, which you can see, or orifice retroplacement may be there, and opacity may be there in very chronic cases, or there may be opaque medium, which is, coming out from the meibomian glands. Then you have to assess the medium quality, which you can actually, depending upon the clarity and the opacity or opalescence of the medium, you can grade from 0 to 3. And the expressibility, again, whether all glands are expressible or not expressible, and one or two glands are expressible or no glands are expressible. Then treatment would vary on the stage of the severity of the meibomian gland disease. For instance, if it is a less severe one, then only environmental modification and eyelid hygiene can be done with expression. But if it is minimal to mild, then you have to change the diet with the omega-free fatty acids, topical azithromycin, topical lubricants, oral tetracycline 250 milligram QID can be given. Then if it is moderate with, then all of the above. Plus, you have to give anti-inflammatory therapy for dry eye, which could be topical cyclosporin. And if it is really marked, then all of these, and then anti-inflammatory therapy for the dry eye becomes the mainstay for treatment of meibomian gland disease. Then you have what is called as amniotic membrane, and which is important for reconstruction of conjunctival corneal surface, ex vivo and in vivo expansion of the stem cells. And amniotic membrane is immunologically inert, anti-inflammatory, anti-angiogenic, has growth factors, matrix metalloproteinases, promotes epithelial healing, inhibits fibrosis, and there's minimal inflammation and scarring. And before you prepare it, the placenta is removed from the elective cesarean section, informed consent is taken, serology is done, and it is stored with the antibiotics, stored at minus 80 degrees centigrade, and then repeat serology is done at 3 months. Storage generally is done at minus 80 degree centigrade for long term and minus 20 for 4 weeks. And then commercially, there are also freeze-dried preparation available, which are stored at room temperature. So the most commonly used amniotic membrane is the cryopreserved amniotic membrane, but you can use other types also. We do not recommend use of fresh amniotic membrane because serology is not done. And sutureless amniotic membrane, which is available as ProCera commercially, but not available in India, can also be used. Then there are basic surgical techniques by which it can be pasted. You can have an onlay technique for burns, then inlay technique for persistent epithelial defect, or it could be a combined technique. Then it can be anchored with the help of Vicryl sutures or 10-0 monofilament nylon sutures or fibrin glue. People have used cautery as well as laser irradiation. And this is just to show a case of chemical injury with total epithelial defect. So washing is being done so that the pH is neutralized. This is acid injury actually. And after this, the amniotic membrane is placed, and first you place glue on it, the fibrin glue which comes, and the amniotic membrane is then placed on it and is pasted so that there is a surface to surface apposition. And if it is a child, then you would like to suture it, but if it is an adult, then we can just paste it without actually suturing it. And this is followed by a bandage contact lens placement. Now, this is again, I wanted to show you what ProCera looks like, the commercial form of amniotic membrane, and that is why I have got this video. So this is ProCera. So it's like a large bandage contact lens on which the amniotic membrane is already wrapped. And then again, this is a case of chemical injury in which it has been placed. And the advantage is that the lids remain apart. So there's no symblepharon in the post-op period. And this is just to show again an alkaline injury. Whenever you have such a case, you have to wash thoroughly, take out each and every debris which is present of the alkali. Necrotic tissue also should be taken out because that can cause inflammatory mediators to be there, and then followed by the amniotic membrane transplantation, which is then put with the help of the sutures. And it does play a very important role in acute ocular injuries. Then this also plays a very important role in acute Stevens-Johnson syndrome. And this is just to show that all those cases where Stevens-Johnson syndrome, they had used this, it was found to be useful because there was less inflammation in these cases. Then in symblepharon, again, it is important tool because this can help to prevent symblepharon. So partial symblepharon, you can put amniotic membrane in a symblepharon ring. So you see that the symblepharon gets relieved. Then if it is a total symblepharon, then again, this is small little pyogenic granuloma which has been removed, and symblepharon ring has been placed after amniotic membrane. So the advantage here is that the surface has become smooth. Although it may not be clear, for clarity, you can do a corneal transplantation at a later time. But if you do a corneal transplantation in this case, where there's so much of corneal shortening, etc., the graft is bound to fail. So what you do is you make a good surface first, and then you can do a corneal transplantation. Then this is a pyogenic granuloma. The treatment of first choice for that would be steroids. If it doesn't respond, then again amniotic membrane can be placed. Then in large pterygia also amniotic membrane can be placed, or in cases of pseudopterygia, for instance, this is a case of pseudopterygia. So this is being removed. And whatever fibrotic material is there, you have to actually pull it out to one side and then cut it so that all the fibrotic strands, they move back. And this is a large piece of amniotic membrane, which is then placed like a curtain onto the ocular surface, corneal and conjunctival both, and then a bandage contact lens so that epithelialization occurs. Then this is a case of keloid referred for corneal transplantation, but these cases you can remove the keloid and the underlying surface will be still not that clear, but enough to give the patient in the post-op period some visual acuity of say 6/24. So again, amniotic membrane has been placed on it. Then this is a persistent epithelial defect, which can be there. So you place a small bit of piece and then you place a larger piece onto it, like a curtain or like a onlay technique, and then a bandage contact lens so that it epithelizes. So this is a neurotrophic ulcer. Again, multi-layered amniotic membrane has been put here, and the success rate is 70 to 80%. Sometimes you have these shield ulcers in a child of vernal catarrh. So this is again, this is removed because if it mechanically rubs the cornea, then this will not allow this defect to heal. So this is removed mechanically, and then again place a small piece of amniotic membrane there and still larger piece, which is then placed with the help of the sutures. Then you have a neurotrophic ulcer in which again the multi pieces of the amniotic membrane are put. So there are 2-3 pieces which are put, then followed by a larger onlay amniotic membrane which is put, followed by a bandage contact lens. And of course, epithelialization occurs over a period of time in these cases, and these cases do well. So this is just to show how the epithelialization has occurred, and this gutter is taken care of after putting amniotic membrane in a case of neurotrophic ulcer. Then even in pseudophakic bullous keratopathy, for the time that they are waiting for a corneal transplant, they have bullae and they have epithelial defects. So again, you can put an amniotic membrane here, and so and when the patient, when you have the tissue for the patient, then the patient can be then treated with a corneal transplantation procedure. This is just to show an amniotic acute Stevens-Johnson syndrome. In those cases where you place amniotic membrane, look at the eyes, they look so so white and so non-inflamed. Where you did not put, look at the eyes, they look so inflamed and hot. So again, this is just to show in those eyes where you did not put amniotic membrane, they have similar front. So always put amniotic membrane in these cases. Now, when you have cases of limbal stem cell deficiency, this is a case of limbal stem cell deficiency with conjunctivalization, vascularization, and pannus, which is there. So you don't know what to do if you do a corneal transplantation, and this is sure to fail because of so many vessels here. So you take a piece of the limbus from this fellow eye, which is normal, and you place it here. So how do you do it? And you sometimes may not even have to do a corneal transplantation procedure. So just to show that if you have a pannus here like this, and if you have cornea here, do anterior segment OCT, corneal thickness is normal. So you will do only surface procedure. But if the corneal thickness is less here, like it is about 320 microns only, then in those cases you will have to do a lamellar keratoplasty, because you can't have a 300 micron cornea. That is too thin. Now, how do you do it? Now, in these cases, this is the fellow normal eye. So you are dissecting 0.5 millimeters into the clear cornea and 1 millimeter behind the clear cornea. And this is the magic wand or the limbus which is there. And this magic wand is taken. And then this 2 things can be done. One, you can grow this stem cells in the lab. So when you grow it in the lab, you break that limbal lenticule into small pieces, and then in the lab you try and grow them. That is grown in a petri dish or a tissue culture plate. And then this is a case of stem cell deficiency. So you remove the entire pannus, and after the entire pannus is removed, this is the amniotic membrane which is taken, on which these limbal lenticules are placed, and they have been grown in the lab. And then subsequently you place it here, and followed by a bandage contact lens. Success rate of this procedure is 60 to 70%. Now, Dr. Sangwan et al. Have come out with a very simple technique, and they call it simple limbal epithelial transplantation, or SLET, for all the cases of limbal stem cell deficiency. So what is done in this case is that you don't have a lab, because everybody doesn't have a lab. So this pannus is removed. Once you remove this pannus, you just see the cornea underneath is so clear. So what you do is that you grow the stem cells on the eye itself rather than on the lab. So this is the amniotic membrane which is here, and then that lenticule, limbal lenticule, which we had taken from the fellow eye, is cut into small pieces, and then it is glued onto the amniotic membrane, and then a bandage contact lens is placed. So those limbal stem cells will grow on the eye itself rather than in the lab. So this is simple limbal epithelial transplantation. And post-operatively, of course, you will give topical antibiotics and steroids. And then over a period of time, the amniotic membrane starts degrading and the cornea starts becoming clearer. So this is the patient who had come to us, and this is how he is cleared. So, and you didn't have to do a corneal transplantation. So these procedures are very gratifying. This is just to show at 6 months. It takes time to clear up, but it does clear up after a SLET. This is at 1 year, then this is at 3 years, completely clear. Then if suppose there's a opacity which is there, then you can do always a lamellar keratoplasty at a later date. And the outcomes are very good. The success rate, they'll ask you in the exams, is 70 to 80%. And of course, all these amniotic membrane transplantation procedures do have some amount of limitation because they don't have a body to it. So it doesn't have stroma to it. So that is the limitation that is there. And sometimes it becomes a little hazy. You can't, see the pathology. Now, what to do in those cases where you have bilateral limbal stem cell deficiency? You can't take from the fellow eye because there's no limbus. So what you do is you take this labial tissue, the lip tissue, which is there in the lower lip, you take this tissue, and instead of the limbus, you place that, grow it on the amniotic membrane, and we call it COMET, cultivated ocular mucosal epithelial transplantation. So what is done is that again your cornea is made clear, and then you place some glue on it, just like you would do for SLET. Then you place amniotic membrane, which has these little pieces of the lip biopsy or the mucous membrane. So you place it here, and over a period of time, this will also clear. Success rate is 30 to 55%, not as high as SLET, but fairly okay. So this is just to show some of the cases how they look like. So apart from this, you can also have lid margin keratinization, which you have in cases of Stevens-Johnson syndrome, for which you have to do a mucous membrane graft. I think that is beyond your course, but you should just know that for lid margin keratinization, in cases in which it is present, like Stevens-Johnson syndrome, etc., you can do a mucous membrane graft. So this is what lid margin keratinization will look like. It is like a whitish thing which is present on the lid margin. And once you do a mucous membrane graft, then you remove this whitish thing and you place the mucous membrane thin graft you place here, so that there's no lid margin keratinization. Then sometimes you do minor salivary gland transplantation. This is just a case to show how in one case, which was PL plus PR accurate, we've done a minor salivary gland transplantation. And so the patient is able to see 6/24. So it's not a great vision, but it is better than having nothing like this. If you do a graft in this eye, it is so dry, it is bound to fail. But from here, the patient can see something. Then coming to the last bit, that is keratoprosthesis, which is done in those cases where you can't do a corneal transplantation because the grafts will fail. So what are the grafts which will fail? Grafts which will fail are the grafts where there are a lot of vascularization, lot of vessels. So what you do over there is, there you do a keratoprosthesis. So this is a 8 millimeters cornea, which is there in the center. You make a 3 millimeter hole. And this is then a cylinder, a PMMA cylinder. And you thread this PMMA cylinder into this hole 3 millimeter which you had created, and this is the back plate. So with the back plate, what happens is that this tight cylinder will become screwed to the cornea, and this is in the front. You put the titanium ring. So this titanium ring is put. Now this is a case which is bound to fail if you do a corneal transplantation. So in this you put this keratoprosthesis. So from the center of the cornea here, the patient starts to see. And then you put 10-0 monofilament nylon sutures. So this is just to show the case. So the patient has vision. And this is osteoodontokeratoprosthesis, which is done in those eyes which are completely dry, and the success rate of this is also 70 to 80%. If it's a very dry eye, you can't do a corneal transplantation. This is again to show that, this case, which had a vision of PLPR with the keratoprosthesis, the vision has improved markedly. So sometimes you have a small membrane which is there behind this keratoprosthesis, and then you have to YAG it, do a YAG removal. Now, this is just to show a cohort of patients who fell into a ditch of sodium hydroxide, and they had varying kind of, lesions. Some had perforation, some had infection, some had stem cell deficiency. Some were all right, so they healed on just medications. So in all those cases, you had to do with all these kind of procedures that I showed you: amniotic membrane transplantation, corneal transplantation, the slit, keratoprosthesis. So this is how, these are those 30 patients who had injury and how they fared after their treatment. So you have to employ all kind of modalities in whenever you have a case of ocular surface disease. So thank you very much for your kind attention, and I think we'll move on to the next talk. Divya.
Thank you, ma'am. That was a very nice presentation. Our next talk is by Dr. Shomashila Murthy. She will be talking on corneal ectasia. Dr. Murthy has done a specialization in ophthalmology at Lokmanya Tilak Medical College, Mumbai. She has done a clinical fellowship in cornea from LVPI and uveitis and ocular pathology from Downey Eye Institute at the University of Southern California. She has over 14 years of rich experience as a full-time faculty at LVPI. Her areas of clinical expertise includes diseases of cornea, anterior segment, uveitis, ocular inflammation, and surgical expertise includes corneal transplant surgery, corneal trauma, refractive surgery, cataract, and complicated cataract surgery. She has extensive experience in conducting clinical trials as a principal and co-investigator. She has to her credit to over 60 publications in peer-reviewed international ophthalmology journals. As an acknowledgement of her achievements, she was awarded the Achievement Award from the American Academy of Ophthalmology. Apart from her clinical work, she is passionate about mentoring women entrepreneurs and participating in team building activities. We are happy to welcome you, ma'am.
Thank you very much, Dr. Divya. Am I audible now?
Yes, ma'am.
Are my slides visible?
Yes, ma'am.
All right. Firstly, good evening, everyone. And I would like to thank Dr. Ashin Agarwal and the organizers to have me participate in this program. It's really my pleasure to be part of Kalpavriksha 2020. And secondly, it's a very hard act to follow after the really, really wonderful talk by Dr. Namrata Sharma. So it's a little difficult to engage the audience after her, but I'll just try to stick to the topic that I've been given. And what I'm going to do is in the next 15 minutes or so, I'm going to take you through corneal ectasias, which is a topic that I have for today. And also, I want to thank my colleague, Dr. Vikas Veerwal, for most of the slides, really. So he made my job very easy. So what am I going to take you through? First, we're going to talk about the definition. How do you define corneal ectasias? And what are some of the differential diagnoses of these various disorders? We'll mainly look at the clinical features and a little bit on the management of keratoconus. I'll not complete the management here in this talk. And then we'll go to the other ectasias as well, because keratoconus being the commonest, we'll spend most of the time on keratoconus. So coming to the definition. So depends on which book you read or which article you want to look at. You can define it as a progressive non-inflammatory thinning, as well as protrusion of the corneal tissue due to unknown causes. It's also an inherent state. So it's inherently that the cornea is weak. So the corneal stroma is weak. So there's a tectonic weakness or thinning. Subsequently, this leads to protrusion, and the protrusion leads to irregular astigmatism. And therefore, there is a resultant loss or decrease of visual acuity. Rarely, there's also can be a risk of perforation, and definitely there can be some complications associated with these conditions. So how do you classify? You can one of the simplest way of classification is to call it as a primary condition or a secondary. It could be an iatrogenic or some other condition like post-trauma, for example. Under primary, we have ketoconus, we have pellucid marginal degeneration, we have Terrien's marginal degeneration, ketoglobus, as well as posterior ketoglobus. Under secondary or iatrogenic, you have all heard about post-refractive surgery, ectasia, post-traumatic, and maybe after a corneal ulcer when there's a desmetocele and then that heals, you might have something what looks like an ectasia. So you can also define it as located centrally. For example, ketoconus and some of the post-LASIK ectasias are located a bit central. Peripheral includes pellucid marginal corneal degeneration as well as Terrien's. And a generalized ectasia is ketoglobus. So coming to ketoconus, we know it can be a progressive condition. Definitely, we traditionally believe that it's a non-inflammatory condition, although there are some newer theories that, and also some research that has been done that has identified certain cytokines and inflammatory molecules, which may put it into an inflammatory condition. But for all practical purposes for now, let's just call it a non-inflammatory condition, and it is progressive. So in which, very simplistically put, the cornea assumes a conical shape. There is thinning of the cornea and there is protrusion of the cornea. And of course, there is associated mild to severe impairment of the visual function. What is the incidence? So earlier it was much less frequently reported, probably because the diagnostic ability of the tests and the equipment that existed was not as good. So some of the published literature says that it was as low as 50 or 230 per 100,000 population, which puts it as approximately 1 per 2,000 that walks into a clinic. But nowadays you see that the incidence is much, much more than that, perhaps because the awareness amongst ophthalmologists is high and the diagnostic ability of our investigations is also very good. So it's about 1 in 600 to as high as 1 in 420 patients that walk into our clinic. The onset, although the patients would present to us in early teenage years, but we know that it may have started a little bit before that, seems to occur equally both in boys and girls. And it's usually isolated. There could be examples of families which are affected by it in different ways, not exactly brother, sister, and so on, not siblings, but some of the family members, but it's usually considered a sporadic disorder. So it's not, doesn't have a Mendelian or a genetic direct association, direct transmission. It is bilateral and it can be very asymmetrical. Sometimes one eye can barely have any features of ketoconus and one eye can have the features. Some of the common associations systemic of ketoconus includes this whole list that I've put here, but of which Down syndrome, Marfan's, and perhaps atopic dermatitis are some of the syndromes that we more commonly see. So you should be aware that when you have a patient who either comes into your clinic with these syndromes, or if you have a patient who appears to have systemic abnormality, could also have ketoconus. The ocular association with ketoconus, the commonest one is allergy, vernal ketoconjunctivitis, and it's most relevant to us in our population. We see very often pediatric patients with ketoconus as well as allergy. The other ocular associations include retinitis pigmentosa, aniridia, Leber's, congenital amaurosis, and so on. So these are some of the common systemic and ocular associations of ketoconus. So coming to the next point, which is about clinical features. In the early stages, it is subclinical, meaning that when you examine the patient, maybe our retinoscopy may not pick it up, our slit lamp examination may not pick it up, but the patient may have astigmatism, and if you do a topography, you might be able to pick it up. So at this point, it is subclinical. So that is really only if the patient incidentally comes to us for a checkup, that's when we may pick it up. The onset being at puberty, it can progress over the next 10 to even 20 years. So till the child grows up into young adulthood, maybe up to the age of 29, 30. And then after that, most of the cases, there is no progression. So if you have a patient who comes in his 30s and you've diagnosed that the patient has ketoconus, more likely than not, it is not going to progress. You don't need to do anything. For example, you don't need to do cross-linking to prevent further progression. It's more likely not going to happen. And as I mentioned earlier, that you can have bilateral asymmetrical presentation. Sometimes you can have bilateral, very symmetrical presentation also. So what are the symptoms? So the patient will have frequent change of glasses. I think that's one of the commonest symptoms that the young adult might come in with. The patient may also complain of distortion of images, both at near and distance, seeing ghosting of the images, seeing multiple images with one eye, polyopia, seeing halos around light, and also complaining of headache more on the side which has the higher cylinder, inability to focus well or to see well. The patients with allergy would also, in addition, have itching, glare, and photophobia. And sometimes you can have a condition called acute hydrops, in which there is sudden snapping or breakage in the Decimase membrane due to the gradual thinning disorder, and there is a stretch on the Decimase membrane. So there's sudden rupture of the Decimase membrane, and the aqueous will leak or seep into the stroma, leading to collection of fluid in the stroma. So there's sudden loss of vision, and some of these patients can have pain and lacrimation and photophobia, and come to you with a white spot. So this is a very acute and dramatic presentation in keratoconus. Coming to the signs of keratoconus, you can broadly divide them to make it very easy for you, for us, for the exams especially, as 5 different kind of entities. So one is the signs based on our refraction for the patient. Second is the signs based on just on external examination with a torch, for example. Third is the ophthalmoscopy. Using the ophthalmoscope and using the retinoscope, you have unusual images that you see there. So that's ophthalmoscopic and retinoscopic signs. And then you can also have the slit lamp biomicroscopy classical findings of keratoconus. And lastly, when you do a corneal tomography and a topography, you will pick up even a subclinical keratoconus using these tools. So coming to the external signs, what is that? So the first one you have is Munson's sign. So Munson's sign relates to when you have a patient with very advanced keratoconus, as a picture on your left. So this patient even has hydrops. That's why you see a lot of edema in the cornea. So it's such an advanced keratoconus, and when you ask the patient to look down, the conical part of the cornea, the protruding part of the cornea, will actually make the lid move down. So that is Munson's sign. So there's a V-shaped protrusion of the lower lid in down gaze. The second one is Rizzouti's sign. And what is Rizzouti's sign? Very often the examiners like to ask, certainly I ask this, there is reflection of the cone. So because there's a thinning of the cornea in the paracentral or the inferoparacentral region, and as the light is scattered onto the nasal limbus from the temporal side, there is this reflection of this due to this cone, and that sign is known as Rizzouti's sign. So the next part was about the ophthalmoscopic and retinoscopic sign. So if you're doing refraction for this patient, and you will see that instead of getting the glow of the retinoscope moving either towards or against, you will have a sort of a crisscross glow. So it's like a scissors. It's called a scissors reflex, and you really need to do that in the clinic to experience what it means. So the shadow doesn't get neutralized or gets neutralized with great difficulty. And in fact, instead of going in one direction or the other direction, it goes it crisscrosses. So that is the scissoring reflex, which is pretty hallmark. And in fact, if the first person who does it if the first test you do for the patient is the retinoscopy, then you can pick it up right from there as soon as the patient walks into your clinic. The second is the Chalus sign, which is nothing but when you use the direct ophthalmoscope to examine the patient's eye, you see an oil droplet kind of a reflex, and that is called Chalus sign. Coming to the hallmark clinical features, which is the slit lamp findings. So these are something that as you keep examining a keratoconus patient, you will find these. Not all are present in all patients, but some of the findings will certainly be present in most of the patients. So you might have apical scarring, which are small stress lines or breaks in the epithelial and subepithelial region. This can also be noted in contact lens wearers, because the contact lens in the center would rub the epithelium, leading to some scarring. Second is you can have Flesch's ring, which is hemosiderin deposition at the level of the basement membrane of the epithelium, which can be an incomplete ring or a complete ring, and best seen with the blue filter. And of course, you'll have stromal thinning, which is the hallmark, what we're talking about. Of course, you'll have ectasia, which is protrusion, but sometimes it can be very subtle, so you may not be able to see it very easily. And because of the thinning in the stroma, you can also have posterior stromal stress line called warped striae, and as well as the corneal nerves are very prominently seen. So you can see prominent corneal nerves. So all these features put together, they point towards keratoconus, and most of them are very characteristic for keratoconus, especially something like Flesch's ring. So this is corneal ectasia. So what you can see is that ideally the slit lamp reflex of the cornea posterior part should have been here, but instead you can see that it's actually bulging forward. So where it started and where it's ending is that it's bulging forward. So this is corneal ectasia. Corneal thinning is very obvious. See the slit beam over here, it's much thicker. And as you go to the portion of maximal thinning, you can see that the slit beam has become thinner, and that is stromal thinning. This one is the Flesch's ring. So you use a blue filter and you can see a dark shadow. And if you see it without the blue filter, what you'll see is brown. It's a very faint brown, and that is Flesch's ring or iron deposition. And this is very subtle. So in this particular case, there are small little breaks and irregularities in the anterior most part. So in the just below the epithelium. So this is the scarring that I talked about earlier. So the last part of how to diagnose keratoconus includes the signs that you see on both on simple keratometry as well as on Placido disc-based systems, as well as on the most sophisticated topography that you can do. So on simple keratometry, what you'd see is high irregular astigmatism. In fact, instead of having nice normal looking Myers like this, if you people have been doing keratometry, this is the kind of Myers that you should get. You'll have very irregular oval Myers. It's as if the ocular surface is very, very bad, but it's not because of a poor ocular surface, but it's because of high and that too irregular astigmatism. If it's regular astigmatism, you can still get a good image, but here you see all this doubling and it's just not able to focus. The Myers don't superimpose on each other. So by keratometry alone, you can in fact sometimes come to a diagnosis. Based on the curvature, you identify mild keratoconus as less than 48, moderate as 48 to 54, and severe when it's more than 54 diopters. We're talking about the anterior surface. So the Placido-based systems are more sort of robust in diagnosing early keratoconus also. When it's advanced, any system will pick it up for you, but for the early ones, this is what you need. And what you see is that there is compression. So this is a representation which shows the various colors, as you probably know. Talks about the steepness, what is the dioptric value of the cornea and how steep is it as opposed to how flat it is. So the inferior part of the cornea, there's both compression of the miles and it's extremely steep over there. And this patient also has a sort of a bow tie, but a skewed or an irregular bow tie, kind of an astigmatism. So there are various criteria that are established based on the earlier video keratography. And one of the most sort of classically or traditionally known one is Rabinowitz criteria, but there are many others. So this is not the only one, but this is something that might be asked. So currently the way to diagnose keratoconus, especially this is a very established case, but you have early types, is to use a pentacam based system. I won't go into details of pentacam, but this is what a map would look like if you use a pentacam with the quad map showing the anterior surface. On the anterior surface itself, you can make out that inferiorly the cornea is extremely the keratometry is going to 53, in fact, diopters is extremely steep here, whereas the superior part looks on the flatter side or normal. And there's a zone where the cornea was almost within the normal range, and then suddenly inferiorly, it's very steep. So this is classic for keratoconus. And if you look at the pachymetry, though these points in this area would correspond to very low pachymetry. So here, if I read out, it's about 450 microns, whereas the peripheral cornea, it's 600, 584, and so on. So the peripheral cornea, especially the superior part, would be normal, and inferiorly it would be very thin. So this is different from keratoglobus, where you would have a diffuse thinning all over. So how do you manage a patient with keratoconus? In keratoconus, it depends on the stage, and it depends, ultimately what we want for the patient is good vision. So it depends on which method we can do to obtain good vision for the patient. So if the disease is in the mild stage, so the patient sometimes can do well enough with glasses, just keep the patient on frequent follow-up. And if glasses do not give a satisfactory image for the patient in terms of vision, then the next step is to go with rigid gas permeable contact lenses. This can be either RGP lenses themselves or special designs like rose K lenses, hybrid lenses, and you can also go with scleral lenses for the more advanced cases. Literally any patient can be fitted with a contact lens from the menu that I just read out. So only problem is that the patients have to use the contact lens, and sometimes it's hard for them, or sometimes they're reluctant to use something that requires some amount of effort and practice. The second management principle would be an interventional kind of management. So either if the patient has very advanced disease or cannot wear contact lenses, doesn't have good vision with glasses, has very high astigmatism, irregular, then you have to go in with surgical modalities. Some of the modalities we simply do to increase the corneal rigidity, especially if it's progressive. So that is collagen cross-linking. And sometimes we place intracorneal rings when the patient cannot wear contact lenses. So that is to increase the rigidity of the cornea, decrease the astigmatism to some extent. So at least the patient will have a better image with glasses. The second option is, of course, corneal transplant. So you are replacing or you're augmenting the weakened areas. So you can do a deep anterior keratoplasty, which is the most commonly done technique, or in very advanced cases or with stromal scarring, especially, you might have to do a penetrating keratoplasty. And earlier, central and peripheral lamellar keratoplasty was also performed, but we basically don't do that now. We usually resort to DAC. The other techniques in patients where we're anyway doing cross-linking or something like that, we can combine cross-linking with photorefractive keratotomy to smoothen out the cornea so that the patient will not have very high refractive error. And provided the cornea is not thin enough and has adequate pachymetry to start with. The second non-glasses or contact lens kind of technique is to use phakic IOL, which is a lens which has required power for that particular patient. And once we know that the keratoconus is not progressing, we can place this IOL in the patient's eye. It's placed on top of, in addition to the natural lens that the patient has, and it's not cataract surgery. And in that case, the patient can achieve some good vision without having to use high-powered glasses or contact lenses. And other techniques such as Bowman's layer transplantation and certain other techniques that CAIRNS, which is probably Dr. Susan Jacob, who's coming, has published and is really impressive technique, will also be described subsequently. So this is just the same thing that I've already talked about, so I'll skip this. And this is just a picture showing what a mini scleral lens can look like. And you can fit a lot of patients with mini scleral lenses and have excellent results for these patients. These lenses are very comfortable, more comfortable to wear for the patients, and we can avoid or avert a corneal transplant till much later on. So earlier I was talking about the diagnosis and talked about several other apart from keratoconus. So let's just quickly go through them in the last part of my talk. So in this particular slide, I'm talking about the first one is keratoconus. The second one is pellucid marginal corneal degeneration, and the last one is keratoglobus. So of the three, keratoconus is most common and the rarest is keratoglobus. All three are bilateral conditions. Keratoconus happens at puberty, whereas keratoglobus is literally at birth, and PMCD happens a little bit later on. It's manifested later on in life. Thinning is more prominent inferiorly in PMCD, and we have already seen that in keratoconus, it is paracentral inferiorly, as well as in keratoglobus, it's in the periphery as well. So the major important difference between PMCD and keratoconus is that the thinning in the case of PMCD is actually inferior to the area of maximum ectasia. I'll just come to that once again. And we see Flesch's ring most commonly in keratoconus. So these are some of the points to differentiate between the three. So this will be confusing if you see a patient who has advanced keratoconus, whether it's PMCD versus keratoglobus. And in early keratoconus, you won't get confused. In a very established keratoglobus, you won't get confused. So this is a schematic just to show you that this is what keratoconus would look like. There's protrusion and thinning. So wherever is the maximum thinning is also the maximum protrusion. In the case of PMCD, there is protrusion as well as thinning, but the protrusion is there first, and then inferior to that, there is thinning. So that's the main difference. And that's why it's important to understand this difference, because that's why the topography is going to look different when you look at a map. And the last one is keratoglobus, where the entire cornea is both thin as well as sort of protruding out right from the limbus itself. So you can remember this by the beer belly appearance. So you have the area of maximum protrusion first, and then followed by thinning inferiorly, like the beer belly of this man here. So this is what a typical map would look like for PMCD. So the main difference you can right away notice is that there's an area of flattening here, which is again reflected down. So whenever you see a zone of flattening below the midpoint, you immediately know from a distance that this is a map of PMCD. So you have the lobster claw appearance, as well as the area of steepening, which is usually in the horizontal axis like this. Rarely you might have a superior or an inverted PMCD also. So this is typical for what PMCD would look like. If you can just remember the keratoconus patient even this area was very steep. So once you have a patient who has advanced keratoconus and you're not sure whether it's PMCD versus keratoconus, this is exactly what you should look for when you look at the topography. Cataglobus, on the other hand, is also, it's bilateral, it's non-inflammatory, and it takes on a globulous shape. Obviously, that's why it's called cataglobus. It's a very challenging disease. Luckily, it's a rarest of the three, and it's typically, it has a high association with connective tissue disorder like Ehlers-Danlos syndrome or with other conditions. The problem with this particular disease is that the cornea is extremely steep all over. So the cornea is taking almost 60 diopters over here, as you can see. And it's not just the steepness, which is still okay. It's that the cornea is extremely thin all over. So if you use spectacles, you just can't correct the high astigmatism. If you want to use contact lenses, it's difficult to achieve because of the abnormal contour. And also, because the cornea is so thin, sometimes it's a risk just to put the contact lens in the eye by the patient. And even such trivial trauma can cause a perforation of the cornea. So what can we do is that the technique that is probably the safest is a two-stage approach. First, you can perform an epikeratoplasty, and then later followed by a penetrating keratoplasty in the central cornea in order to improve the visual acuity for these patients. But this is one of the cases that we had done. But such cases are always, there are multiple challenges, and it should not be the first option, hopefully, for these patients. Coming just in towards the end to Terrien's marginal degeneration. So it can be superior or inferior. It can present with inflammation, although it's ideally a degenerative condition and not perpetually not an inflammatory condition. And it has high against rule astigmatism or oblique astigmatism. Sometimes we get confused and we think it's a peripheral ulcerative keratitis kind of disease. Sometimes you do need low dose steroids, but the best way to rehabilitate them visually is contact lenses and use surgery as a last resort for them. So these are some examples of Terrien's. When you see this peripheral thinning with the pannus and lipid deposition, so this is absolutely classical for Terrien's. Most commonly it's superior. Sometimes, rarely, it can also be inferior, as in this case. And this is a sheet which shows the various differential diagnoses, includes PMCD, Terrien's marginal degeneration. It could be Morin's ulcer sometimes, which is a kind of a peripheral ulcerative keratitis sometimes, which can be confused with peripheral corneal ectasias. So it should not be. So with that, I end my talk, and I thank everyone for listening in, and I'll be happy to take up any questions if you have any.
Thank you, ma'am. That was an excellent presentation. I think we'll have the questions in the chat box.
We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone.
Then I'll take it. I would have sorted by that time.
Sure, ma'am. Dr. Susan?
Susan is there? I think she's not there. Anyway, I'll take it up. Doesn't matter. No problem.
Thank you so much.
Thank you, ma'am.
So I'll be talking to you about component surgery of cornea, and this will cover the entire gamut of keratoplasties, and there are no financial or proprietary interests. Now these figures, you can just mug it up because you need to know these figures. So corneal blindness is about 1 to 1.2 million bilateral corneal blind in India, 5 to 6 million unilateral corneal blind in India, 50,000 new estimated cases per year, and the goal is 100,000 transplants per year by 2020. And of course, we have not been able to fulfill this goal, and this goal has now shifted to 2025. The corneal transplants, corneas which are required each year is 2 lakh. The total cornea that we collect is about 50 to 60,000. The total transplants that we do are about 50%, so about 26,000. So the utility rate, like I said, varies between 45 to 50%. And the indications of corneal transplantation are optical, tectonic, therapeutic, and cosmetic. So you have good to fair prognosis for cases like keratoconus, healed keratitis, dystrophies, and degenerations where there's hardly any vascularization, but in those cases which have vascularization or which are dry, such as grade 4 chemical burns, staphyloma, Steven-Johnson syndrome, dry eye, there you have bad prognosis. The preoperative evaluation consists of ocular history and exam, visual acuity, slit lamp evaluation of conjunctiva and cornea, anterior segment and iris, lens, intraocular pressure, and fundus evaluation, which is generally not possible in most of the cases. And two very important investigations, apart from the investigations which you see here, are pachymetry, that means the corneal thickness, and the anterior segment OCT. Again, you should do a tear film status, try to do a corneal topography, do a ultrasonography, because at least the retina should be good and there should be no posterior segment evaluation if you're doing a corneal transplant procedure. And these are the instruments which are required: disposable trephines, Hesburgh-Barron suction trephine, dermatology punches for smaller graft, scissors, Teflon block to punch the graft, Barron punch, which has these pillars sort of thing, so that the graft which is punched has more vertical edges. And we know penetrating keratoplasty for last 115 years. We are all familiar with it, but we are also familiar with the problems of penetrating keratoplasty. So this is a full thickness penetrating keratoplasty, a case of keratoconus with healed hydrops. And so trephination is done, and after doing the trephination, some viscoelastic is placed, and then this is the cornea, which is sutured with 10-0 monofilament nylon sutures, interrupted sutures. Now again, penetrating keratoplasty has a very important role to play here in cases of infections. So you encompass the entire pathology, about 0.5 to 1 millimeter into the clear area, so that you remove the area of infection, debulk the microbial load, AC infiltrates and membranes, wash with the antibiotics and the antifungals. The graft host disparity should be 0.5 to 1 millimeter, and then 10-0 monofilament nylon sutures, you suture the graft. So the idea is that you've debulked the amount of infection that was there, and also now when the antibiotics act, they have less amount of infection to control. Now, sometimes you have to make these grafts by hand, like in this case, the membrane is present there, so that is removed. After removing the membrane, AC paracentesis is done. The edges of the punched out area are fashioned, and then with 10-0 monofilament nylon sutures, you place the graft there. So this is a graft where dermatology punches have been used. These are patch grafts. Now, there are various types of suturing techniques which could be interrupted, which are generally done for pediatric and therapeutic grafts. Why in pediatric graft? Because the healing is fast. Why in therapeutic grafts? Because there may be infection. So you don't want to remove the entire suture. You just want to remove the suture where infection has occurred. Then you can have combined interrupted and continuous, and then you can have single continuous, which could be torque, could be anti-torque, or could be no torque. Now, it does not matter what type of suturing is there. Generally, in all of them, the astigmatism is going to be similar. So penetrating keratoplasty was being done for a long period of time, is still being done for cases which have full thickness pathology, but it has problems of long postoperative visual recovery, ocular surface problems, graft rejection, increased chances of wound rupture after trivial trauma, change in anatomy of the angle of the anterior chamber. So you can have suture related problems such as this: tight sutures, loose sutures, infected sutures, and high astigmatism, persistent epithelial defect, graft infection, even endophthalmitis. And sometimes when the graft is so clear, then also there's a problem of astigmatism. So the patient is not able to see. So you have to do suture adjustment here, because here it is steep. When you adjust the suture, take off the tension from the steeper area, it becomes flatter. Now, of course, the most ominous complication is this, that is expulsive hemorrhage. So there can be vitreous prolapse, there can be retinal detachment, there can be intraocular contents which are extruding out, and a frank expulsive hemorrhage. Now, I always show whenever I show penetrating keratoplasty, because I myself saw this case of expulsive hemorrhage looking like this after almost 20 years of being into cornea. So that is why I want you all to see at this age what an expulsive looks like, so that you know how to manage it if you have it, because this is the most dreaded complication. So we moved from an older era of overkill therapeutics, where we just did a penetrating keratoplasty, to a more customized approach where we are doing layer by layer replacement of the corneal tissue. So for anterior pathologies, we are doing anterior lamellar keratoplasty, which can be done manually or can be done by automated techniques such as automated lamellar therapeutic keratoplasty. For posterior diseases which are involving the Descemet's membrane endothelium, we are doing posterior lamellar keratoplasty. So initially we used to do this lamellar dissection. This is a King's clamp. It is placed in your exams for Viva. And this is the Desmar's lamellar dissector which is being used. So notice what happens here. What happens here, you see so many corrugations there which you can see. So if you try to dissect it with the hand, this is what happens. The graft will be irregular. Now how will it manifest? It will manifest like this. There will be interface haze present in the post-op period. So this instrument, that is the microkeratome, brought about a revolution in the field of corneal transplantation procedure because it was technically easy, less time consuming, with a smooth host donor cut, thickness was nearly exact, and there were no interface problems. So again, for these cases, it can be done where anterior pathologies are present. And in this, the corneoscleral rim is taken. So this is your 500 microns cornea, and this is being split now, 350 microns anteriorly and 250 microns posteriorly. So that this video is not running. I'm sorry about this, but this is a case of keratoconic cornea from which the partial thickness of the cornea is removed, which is diseased, and from here you take the part which is being dissected anteriorly, and you place it over here and place it with sutures. So there is an interface in ALTK, but the interface is quite clear. It is not hazy at all. And these are some of the results to show the same. So the opacity is taken care of. The keratoconic cornea becomes much better because that steep part of the cornea is pressed by your lamellar graft. And if you look at the results are good, the best corrected visual acuity ranges from 70 to 94%, better than 6 by 12, astigmatism is less than 4 diopters. Now, if you go deeper, you will have deeper pathologies, and for that you do deep anterior lamellar keratoplasty, which can be done using DSS or viscoelastic or air. So these are the scientists who describe those techniques of DALP. And what happens? You have only this bare Descemet's membrane which is looking at you. There is no interface and it is quite clear. So again, it will be done for all those cases where the Descemet's membrane and endothelium is intact, but you have ectasia, stromal dystrophy, ocular surface disease, even desmetoceles. And of course, it is contraindicated in cases of healed head drops and endothelial involvement. So a word about Dua's layer, because you may get a short note, 55 to 20 microns thick with 5 to 11 compact lamellae of collagen fibers, type 1 collagen with elastin, and it is continuous with the trabecular meshwork. So this is how it looks like. So if you have Dua's layer, it will appear a little rough. But if Dua's layer is missing, then it will be very smooth. So when you make a air bubble, type 1 bubble will have a rough surface and type 2 bubble will have a smooth surface because it is present between Dua's layer and the Descemet's membrane. And you might get this question again, how do you differentiate between type 1 and type 2 bubble? This starts from the center, this starts from the periphery. This is a much smaller bubble, this is a much larger bubble. And I've already told you the physiology that this type 1 bubble, you have Dua's layer and posterior stroma, the plane of cleavage, whereas here it is Descemet's membrane and Dua's layer. So this is just to show how you do a big bubble DALC. So air bubble is instilled. As the air bubble is instilled, the Descemet's membrane falls back. So this is an inverted image, and as you give a nick in the overlying stromal layers, the Descemet's membrane, like a live show, is marching up. And again, you put viscoelastic, so you can see like a kangaroo's pouch. The Descemet's membrane is going at the back. So when you remove the overlying stromal layers, you are still extraocular because the Descemet's membrane is there on the top. So you've not penetrated the eye. So there are no problems of intraocular problems like expulsive hemorrhage, cataract, glaucoma. All these problems are not there. And this is just to show a case of Hurler syndrome for which DALC was done. Visual acuity is 6/9, 6/12, and it's an extraocular procedure. You've not penetrated the eye at all. Even in desmetocele, you can do it. It is very easy. You put viscoelastic from the edge of the desmetocele. The whole thing will come off, and all that will remain will be your Descemet's membrane on which the graft can be sutured. Now, about peripheral corneal ectasias, keratoglobus, the cornea will look globular. Dr. Somshila Murthy has explained so very well the differential diagnosis of corneal ectasias. And in this case, you do a technique which is called as the tuck-in lamellar keratoplasty technique. So if it is a case of keratoglobus, you will have a partial thickness, you'll have a full thickness cornea here, but you'll have a peripheral flange which will be 360 degrees all around. If you have a pellucid marginal degeneration, then this flange will be there only inferiorly, because that is the area which is thinned out. So this is just to show you that how do you dissect in cases of tilt. So you do a partial thickness dissection, then you make a pocket all around, and you remove this frill, and then you suture it onto the keratoconic cornea after making this pocket all around, and then you suture it up. I'll just show you because this movie is not running in this video. So you can see that there's a thick flange which is there all around. So pellucid marginal degeneration, your inferior part is thinned out. So what you do is you flatten it completely and you reinforce the thinned out part. In pellucid, it will be a sector. In keratoglobus, it will be 360 degrees. So you suture it with 10-0 monofilament nylon sutures. And this is how it will look like. Coming to posterior lamellar keratoplasties, I will not be talking about PDEC because I think that will be covered by Ashwin. I'll be only talking about DSEC and DMEC. So DSEC is when you're using stroma and Descemet's membrane for posterior corneal pathologies. DMEC is when you're using pure Descemet's membrane roll. So this is the advantage. There's no suture at all with DSEC and DMEC as opposed to penetrating keratoplasty. So if you have cases of bullous keratopathy, fixed dystrophy, failed PKPs, eye syndrome, CHED, corneal decompensation due to any cause, endothelial decompensation, you can do a DSEC. The good thing is that after DSEC, the rehabilitation takes only 3 months. After PKP, it takes 1 year. After DMEC, it takes 1 month. And because there are no sutures, there's no astigmatism. So these are the cases which are suitable for DSEC. But if you have a scarring, it's not suitable for DSEC. And there are various ways in which the graft can be put. So I'll just show you this one case, fixed dystrophy. So the epithelium is being removed from here. Then this is the Descemet's membrane which is scarred. This is also being removed because this is a case of Fuchs. There was a cataract there. So we did anterior capsulorhexis and this is also being removed. Foldable lens is put. And this is the lenticule actually. So with the ALTK machine, you do a dissection, split the cornea into 350 and 200 or 350 and 150, and the 150 part you take and you put it on the Buson's glide, get it inside the eye, and then put air bubble and then center it like this. And this is what the patient sees. There are no sutures at all. 5 years down the line, 612. So this is just to show the same on an IO intrapository microscope. So you can see this is how the graft is pulled inside. And then once the graft is pulled inside, you inject the air bubble. Once you inject the air bubble, the graft sticks to the back of the cornea. So no sutures. So one cornea can be used for 3 patients for limbal stem cell transplantation, for anterior lamellar keratoplasty, for posterior lamellar keratoplasty. And this is to show you the same. It is used for DSEC, ALTK, and limbal stem cell transplant, only one donor cornea. So we've helped 3 patients. And this is the DMEC, in which the Descemet's membrane is removed from the back of the cornea. So you stain it with the trypan blue dye, you just remove it, then you lay it back and trephine it, 8 millimeters graft. So this is this pure Descemet's membrane roll, which is completely physiological, and this can then be used for posterior lamellar keratoplasty. This is again a case where the Fuchs dystrophy is present. So diseased Descemet's membrane is being removed. This is the pure Descemet's roll which we had taken earlier. This is taken, this is placed inside in the anterior chamber. A suture is applied. Now you can see in this the graft is moving. This is not the correct orientation. You have to have a biceps curl upwards, biceps curl upwards. Then you know that it is a correct orientation, endothelial side down. And then you put the air bubble. So once you put the air bubble, the graft gets stuck to the back of the cornea. This I will skip because Ashwin will show. And this is in the post-op day. And this is at post-op week 1. And just see that you can't make out any graft or any surgery, any corneal transplant has been done for this patient. Now, femtosecond can also be used to do laser-assisted keratoplasty, and this is the graft which is cut by the femtosecond. And following this, the anterior part of the cornea is removed. So it gives good cuts, but for deeper cuts, it's not that good. Superficial cuts are good by femtosecond. Somebody asked about bioengineered corneas. So we are working on bioengineered corneas, which are synthetic corneas, which have been obtained by recombinant technology. And they look very much like your bandage contact lens. This is a case of keratoconus. So a pocket is being made here, and this pocket is opened with the help of the blade. And after opening it with the help of the blade, this is the synthetic cornea which is taken. You can see this is the synthetic cornea, looks like a bandage contact lens. This is folded, and then you place it inside and then unfold it. So once you do that, there is a tissue which is added to it, so it becomes thicker, and then this is the bandage contact lens. So these are biosynthetic corneas which are good for anterior lamellar grafts, but not so good for posterior lamellar grafts because they don't have endothelium on it. So this is in the post-op picture, and the graph clears up. So this is again something which people are going to be asked. Endothelial cell loss in general population is 0.5% per year. PHECO is 6 to 8%. PKP is 25 to 28%. DSEC is a little more, 28 to 30%. DMAC is again a little more, 30 to 35%. DALC, of course, because you're not touching the endothelium at all, is 4 to 6%. Graft rejection for DSEC is 7%. For PKP, 7 threes are 21. So 3 times more, 21%. And for DMAC, because it's just a single layer, is 1%. So you should mug these up because you may be asked this in your exam. So to conclude, we have an important thing, that is full thickness penetrating keratoplasty, which is the commonest keratoplasty which is performed. But there are other surgeries where the disease layer is replaced by the healthy one, and component surgery of cornea is here to stay. Refinements in techniques and modifications will continue to occur. So thank you so much. This is the book that on corneal transplantation, DALC and DSEC. And this is the book for the post-graduation ophthalmology clinics, which we've done, which has long cases, short cases, spotters, instruments, darkroom procedures, viva voce, expected questions. And we also have one on investigations and darkroom procedures, a separate one which has come out. So just before your exams, you can go through these. Thank you very much for your kind attention.
Thank you, ma'am. That was an excellent presentation with those nice videos and clinical pictures. I think after day one session, students will be very much interested in cornea. Thank you once again, ma'am.
Hi, Susan.
Oh, Soundri, you can take over.
Yeah. And now we welcome Dr. Susan Jacob. Susan Jacob is our in-house speaker. She is the director and chief of Dr. Agarwal's Refractive and Cornea Foundation at Dr. Agarwal's Group of Eye Hospitals, Chennai. She has won more than 50 international awards for her innovative techniques and video films. She has won Golden Apple Award for Most Outstanding Case in Complication and Challenging Cases Symposium in Cataract Surgery at ACRS. She has won the John Hanahan Award. She has got the Innovators Award from Connecticut Society of Eye Physicians. She is the chair of International Society of Refractive Surgery Multimedia Editorial Board. She is in the editorial board of prestigious Journal of Refractive Surgery, Ocular Surgery News, Asia Pacific Edition, Eurotimes, Glaucoma Today, Indian Journal of Ophthalmology, and TNOA. Innovation is synonymous with Dr. Susan. She loves innovation. Some of them which are close to her heart is Pearl, CSAXL, and CARES. Today, she's going to talk to you on pentacam and refractive surgery. Over to you, ma'am.
Thank you, Soundri, for that lovely introduction. I'm going to have a hard time following up after Namrata ma'am's talk because that is really a tough act to follow. But I'm going to try my level best. Let me just share my screen. Okay. If I think my screen can be seen right now, Soundri, right? Okay. So my talk is on pentacam. And when we talk about pentacam, basically we are talking about, just one second, I'll just put my timer on. Okay, so when we're talking about, when we're talking about pentacam, we are basically talking about how to, study the surface of the cornea as well as the thickness of the cornea and all other measurements of the cornea. So a pentacam is a tomographer. It's a corneal tomography machine. It is different from a topographer in that it doesn't just study the anterior surface. It studies, just like I just mentioned, the thickness, the posterior surface. In fact, it also studies the anterior chamber, the lens, the iris, and a lot of other things. So it's basically like taking a cut section or a thin slice section through the eye, through the anterior segment of the eye. Now, the principle that it works on is the Scheimpflug principle. And basically, this is very simple to understand. In conventional camera, what happens is that the picture plane, the objective or the lens plane, and the film plane are all parallel to each other. But in a Scheimpflug principle, what happens is that the picture plane and the film plane and the objective, they all intersect at one point, and this gives you an increased depth perception. And basically, you can get elevation data from this scan. And the beauty of elevation data is that it's much more precise, it's much more repeatable, it's not too dependent on the tear film, and you can also capture a lot of information, or rather calculate a lot of information from this mathematical input of elevation data from multiple points over the cornea. So you can calculate the curvature, you can calculate the aberrations that are arising from the corneal surface, and a lot of other things. You can calculate the pachymetry. So there's a lot of information that you can get from the pentacam machine. In fact, if you just sit with the pentacam machine, you will find that you can actually spend hours on it and come out with more and more data. So, like I said, the Scheimpflug-based systems, there are others as well. There's a Pentacam, which is the Oculus. There's a Galilei, which is from Zymer, and that has a dual rotating Scheimpflug and Placido integrated. The Sirius has a mono rotating Scheimpflug and Placido. The TMS Tomy has a mono rotating Scheimpflug and Placido as well. So, coming to the Pentacam specifically, this is the kind of map that you see in a pentacam, and it has various sections or segments, which each of them have to be studied individually. The first one is a patient demographics. If you can see my cursor here, which gives the name of the patient, the first and last name, of course, ID, the date of birth, which is very important in a large number of clinical conditions, because you want to, in corneal conditions, know whether the patient is young and more predisposed to ectasia, or is he older. All these things you really do need to know. So then that's important. You also have the eye. And other information, if you want, you can put in. Then you come to the keratometric, values. What this gives you is basically the K1 and the K2, which is over the central 3 mm zone. So this is similar to the SIM-K, the flat and the steep K and K1 and K2. You have the mean keratometric value given here. And these are the radius of the corresponding radius of curvatures that are given to these dioptric values. You have the astigmatism that is given here along with the flat axis, and you have the radius of minimum curvature and radius of the peripheral corneal curvature, which is between the 7 to 9 mm zone. Now, another very important thing that you need to look in this part of the map of the the numerical data is the quality specification. So actually, this is the first thing that you look at when you look at the pentacam map, and you need to know that the map is reliable, that it's a good quality map with good data. So this is the reading is put as okay, and it is in white, it's highlighted in white if it's got good, if it's a good capture. If it is not, that means your capture is not good. Either the patient moved, or he blinked his eyes, or you don't have a good peripheral data points. Maybe you've missed that out because the lid was drooping, and some of them might be extrapolated data, which can lead to errors in what you're going to interpret from it. And so many other problems can happen in quality specification. So that's important to look at. You also have the shape factor of the cornea, which is a Q value here, which gives you an idea of the asphericity of the cornea. So the normal values are in the negative range, minus 0.2 to about minus 0.45, and that's generally the normal prolate cornea. In an oblate cornea, it goes into the positive side, that's more than 0. And in very hyperprolate corneas, it can go up to, it can go higher, more into the negative range. So in keratoconic corneas, you'll see much more negative values here. Then you finally come to the corneal values, the pupil values, and this is the back of the cornea, the same thing. So this is basically the front of the cornea. This exact same thing is repeated on the back of the cornea. If you see this gives you the flat and steep axis in the central 3 mm zone. So the blue is always a flat and red is always a steep. So that gives you the back cornea, and here you get the pupillary data. So you have the pachymetric data here in the pupil center. You have the pachymetric data here at the apex. So apex is always 0 and 0. That's always standard. So this gives you the pachymetric data here. the pupil center is always marked here, and this is very important in terms of knowing your angle kappa, the chord mu length and all that. So chord mu is of course a very important concept now, where it lets you know whether the pupil center is more displaced from the apex or not, and a greater displacement can lead to visual aberration. So ideally this value should be less, and the pupil center and the apex should be close to each other. You can calculate the chord mu actually by using the Pythagoras theorem and putting in these two values, and that will give you the length of the chord mu. So and just on that topic, I'll also just add that Dr. Amar is now is been using this chord mu quite extensively to try and do a pinhole pupilloplasty which is centered on the visual axis. So now you come to the other data that's over here, which is basically the thinnest location that's given over here, and this gives you the location. So this is the x and y axis exactly. You can that's the exact measurements, and that's the pachymetry at the thinnest location. You also have the steepest k, that is a k max on the front surface that's given here, and also the location of the k max. In addition to that, you have some anterior chamber values that are given here: the corneal volume, the white to white corneal diameter, the chamber volume, the smallest angle. So here you can see in this case is it's a wide angle, it's about 40 degrees. So it's an open angle for this patient. Anterior chamber depth is given here, and that's the internal anterior chamber depth, which means from the endothelium. You can also change the device settings to get it as an external, but internal is of course what is preferred, and the pupil diameter, and you can also get corrected IOP measurements. Now coming to this part, which is again a very important part, you can see you can actually put in different kinds of maps into these displays, but these are the most commonly used displays here. And this is the front elevation map, this is a back elevation map, this is the sagittal curvature or the axial curvature map, and this is the pachymetric map. And you'll see also these color coding bars on all sides, and these are actually, you can put them into absolute scale or relative scale. Absolute scale is generally preferred because it's got a lot of machine, you can actually compare it between different readings taken on different machines. So this is here the scale is fixed. If you take a relative scale, you can actually pick up very small irregularities on the patient's cornea, because the maximum and minimum comes down to the patient's maximum and minimum. So small things are enlarged, and you can pick up, it's useful as a screening thing, but generally what people use is the absolute scale. So this is the anti-elevation map as we saw here. And another very important thing that you need to know in case of pentacam is what is the reference surface that you're going to be using for getting all this elevation data. So basically elevation data refers to basically how much the cornea is elevated. But what are you talking about? Elevated from what? So just to explain that, I'll just go down to a slide that's a little further away. This is what you call as a best fit sphere. Okay, this is a reference surface, and this reference surface is taken to fit the corneal shape in the best manner. You can have different kinds of reference surfaces. You could have a best fit sphere, you could have a best fit ellipsoid, you could have a best fit toric ellipsoid, a best fit toric, torus, and so many other shapes. And you can also have this best fit sphere to kind of be fixed to the corneal epithelium, or float and just come to the best possible fit that is there to that particular cornea. So now once you have the best fit sphere, everything that's above the best fit sphere is marked as positive elevation data, and everything that's below the best fit sphere is marked as negative elevation data. And of course we know the Louisiana color coding system, warm colors are marked as positive, and cold colors are negative. So here you can see that this cornea is more elevated in the center, and it's less elevated from than as compared to the best fit sphere in the periphery. So this is how you basically get the elevation data. And so this is important to see what kind of reference surface you have compared it with, because if you have an astigmatic patient, and if you're going to use a best fit sphere, you can pick up both the astigmatism very well. But if you're going to use a best fit toric ellipsoid, it would also fit well to the astigmatic part, and that would be a useful reference surface for picking out higher order aberrations. So then there's a lot of other data which I think may not be as important for you as, for example, the surface of the diameter of the best fit sphere and all that. But this is basically the shape that you see here. You have to look at the qualitative and quantitative analysis, and we'll come to that later. The same thing comes for the best fit sphere, a similar manner. You can understand it for the back surface of the eye, of the cornea, I mean. And then you have the axial or the keratometric maps here. This is axial or sagittal curvature map, which is shown here. And you have all these values that are given here. The steep axis, the flat axis is marked out. And you also have here, you can see the pachymetric map. And again, you all have a lot of numbers there. So now just coming back to this, yeah, we just talked about the angle kappa and all that, but this another thing that you need to know when you see these maps are all these signs. So these signs will actually denote the different points on the cornea. So you have the pupil center marked with a cross, you have the apex marked with a solid white dot, you have the thinnest location marked with a black circle, and the K-max is marked in the form of a kind of a star. So it's a little important to know all these. Uh, the other things that you can do with the pentacam are also very interestingly. You can also take these images, which can actually act as an anti-segment OCT machine, kind of, where you can actually take slit images. So sometimes when our ASOCT, if it is not working on a particular day, we use this instead to kind of get cross sections through the cornea and the iris and the lens, and you can also use that with a caliper that is given and measure. But of course, it's not as, the measurements are not as precise as you get in an anti-segment OCT, especially in FD OCTs, but that is something that you can do if required. You can also get the densitometry, which is basically how radio opaque, I mean, how opaque or transparent the cornea is. That can also be measured. So you can also evaluate corneal scars or the density of the nucleus and so on and so forth. And you can also construct a virtual eye. This is basically the anterior surface of the cornea. The green shows the posterior surface. The blue shows the iris, and the yellow shows the lens, and you can rotate this around to see different parts of the eye. For example, if you have peripheral anticyanic, you could actually see that there when you rotate the eye. So we just talked about the Westwith here just now, and coming to each of those individual maps in a little more detail, because you do need to know them. You have the anterior and posterior elevation maps, as we said here. You have to do a quantitative analysis and a qualitative analysis of these maps. So at a best fit sphere of 8 millimeters float mode, if you have more than 8 millimeters anterior elevation, that's considered to be abnormal, and more than 16 millimeters posterior elevation is again considered to be abnormal. So this is almost similar, just what I just told you. And you can see here, in this case, it is abnormal, obviously, because these are highly elevated points, values that you see here. I'm going to skip through a little bit because I think we're running a little short of time. But anyway, the qualitative analysis, when you look at it, the normal shape of the cornea is basically an hourglass, which is, it should be like this. This is with the rule astigmatism that you see here. It's the with the rule, in case of elevation data is exactly opposite to the keratometric. So you'll see actually blue up and down. This is with the rule anterior, and this is with the rule posterior astigmatism. So that's a normal cornea, and you can have abnormal shapes as well, as in this case with the keratoconus. So lots of abnormal shapes. You can have a skewed hourglass, and when you see this, especially, you should think in terms of misalignments and a large angle kappa and so on and so forth. Other shapes, abnormal shapes seen here. Here's a central cone, as you can see in the elevation data. This is the anterior elevation data. Again, more decentered cone, irregular cones, so on and so forth. Posterior elevation data is also similar. Again, as I said, a normal picture is like an hourglass, and all these abnormal shapes also you can have. You then come to the keratometric map, which is again an important map, and you can have different types of interpretations there, or maps projected onto that map display screen. So you can have tangential curvature map, which is basically the exact tangential curvature corresponding to the corneal curvature at that point. Or you can have axial curvature, which is basically a perpendicular drawn to the tangent, and the curvature that where it cuts the optical axis, that is where the axial curvature is measured as. And the tangential curvature map basically brings out small abnormalities also. So this is the same patient. This is the axial curvature, as you can see here. This is a tangential curvature. So it kind of localizes, helps you in localizing irregularities to a greater extent. You also have various kinds of power maps, and I think I'll not go into this, but basically it is, it corrects some of the errors that have crept into calculation of corneal power over time, which is basically, a standard shape of the anterior and posterior surface, which is being considered for so many years. The refractive index that we use for calculations is wrong. We consider only the anterior plane, and we don't consider the principal plane of the posterior cornea when you're, doing all these measurement calculations, for example, for IOL power. So all these things are corrected, and you can have various other kinds of maps which can correct all these errors and give you a more accurate representation of the corneal power. So when you look at keratometric maps, again, you have quantitative analysis and qualitative analysis. So quantitative is basically steep K more than 48, difference in K max between the two eyes more than 2 diopters, K max minus steep K more than 1 diopter. So all these you'll get in books. It's nothing that's very new here. You can just check it up later on. A skewed radial axis more than 22 degrees. Superior minus inferior more than 2.5 is significant, but inferior minus superior, of course, inferior steepening is always more significant. So a value more than 1.5 becomes significant. And then you can have all these different kinds of, altered keratometric maps here. So this is a round cone, an oval cone, a superior steep, inferior steep, irregular cornea. This is a symmetric bow tie. This is a symmetric bow tie with a skewed radial axis, as you can see here. So what you do is you draw an axis between the two limbs of the bow tie. You draw a line there, and then you look at the axis between the angle between them. And if it's more than 22, it's called a skewed radial axis. This is an asymmetric bow tie. Inferior steep, asymmetric bow tie, superior steep, as you can see here, and this is an asymmetric bow tie with a skewed radial axis. So skewing of the radial axis is quite significant if you see that, as also steepening inferiorly and so on. So this is just examples of maps where you can see superior steepening here. Coming to the pachymetric map, again, quantitative and qualitative analysis is important for the pachymetric map as well. So you can check the thinnest location. If it's less than 470, it is definitely significant. Superior minus inferior pachymetry more than 30 microns at the 5 millimeter zone again becomes significant. So these are calculations. Pachymetric at the apex minus the thinnest pachymetry more than 10 microns. And also another important thing that you need to look is the thinnest location, the y coordinate, which is what you saw in the numerical data map. So if this is more than 500 microns, that again becomes significant, but because it implies that the thinnest location is starting to move inferiorly, and that's quite significant of keratoconus. Also, an inter-eye asymmetry, which is a difference between the two eyes. In many of the parameters, that becomes significant also, because generally in a normal person, the two eyes are quite symmetrical, and actually you have enantiomorphism, which means they have mirror symmetry. You come to the pachymetric map qualitative analysis. Normally what you get is a concentric map. So what you would get is basically something like this, what you see here, which is basically expanding zones. But then when you get these kind of abnormal shapes, obviously there's something wrong with these corneas. And you have certain beautiful, calculations and maps, the corneal thickness spatial profile, which is basically 22 concentric rings which are drawn on the thinnest location, and from that you do these calculations. You have normative data, and here is how this is expressed. This map, this is what it looks like, this graph. So you have the population average, and you ideally the patients is denoted by the red line, and it should fall between these two lines. And abnormal shapes can you can look at the shape abnormality, or basically upward or downward shift of the entire patient's map. You can also have a percentage thickness increase, which shows you how fast the thickness is progressing from the thinnest location to the periphery. So we know that in keratoconus or other ectatic disorders, there's a lot of variation, more than the expected variation between the thinnest location and the thickest point. So that difference in the pachymetry is exaggerated in ectatic patients, and that is what is brought out or made more prominent in these maps. These are other values that are given for easy calculation. You also have something which is very, very important to know, which is the BAD scale. And this is basically an enhanced reference surface for understanding for bringing out ectasia or early abnormalities in maps. So if you look at a patient who's got an elevated cornea here, your best fit reference, the sphere, it actually moves up a bit. So the amount of elevation from the best fit sphere here is not as much as it would be if you had a best fit sphere that was taken down. So what you do in an enhanced reference surface is you exclude this area, which is centered on the thinnest point. You exclude about a 3.5 millimeter zone. This is not taken for any kinds of calculation for the best fit sphere. Once that is excluded, the best fit sphere moves a little bit downwards. And so any increased elevation is made more prominent in that manner. And so you can pick up early cases. So here's a patient, basically this is normal map. Here you can see these are all, there's no difference. This is the front elevation surface, this is the back elevation surface. These are normal, this is with the enhanced surface, and this is the difference. And here is the corneal thickness spatial profile map and the percentage thickness increase. And you also have a lot of progression indices here and D values, and the big D, or the value here, that if it is more than 1.5, it becomes significant. So here's a patient who has ectasia here, and you can see how the difference is picked out, how just using an enhanced reference surface made it more prominent as compared to the previous one. And this is what the use of this Bellin Ambrosio enhanced ectasia display is. Okay, I'll skip through this and also yeah, just show you this one thing, which is basically a screening map, which if you just do this for any patient, you can kind of, it tells you what are the abnormalities that are possible in all the different measurements that the pentacam takes. So it does a lot of things, chamber angle, minimum pachymetry, and so many things are analyzed in a single map. And this is the patient's, the black shows where the patient lies, and the scale actually shows the population normal. And if it's going beyond into the gray zone or the darker zone, it means that there's something abnormal here. And the map, the machine actually gives you a tab where it's, it tells you that you can go to this particular map to study this further, and you can do that. So this is a fast screening map. And I think basically with that, I will this is basically enantiomorphism, which is what I said, mirror symmetry between the two eyes. You can see it's so symmetric. Anti-elevation maps are mirror symmetric. These are the post-elevation maps. So everything is kind of very symmetric between the two eyes, and that's what you would normally expect. With that, I'll come to the end of my presentation on pentacam, and thank you so much for listening to me. Can I just carry on now, Soundri, with the second one, or?
Yes, ma'am, you can go ahead.
Okay, so I have to share a different screen for that. Just 1 second. Can you see my screen? I'm not seeing it.
No, I'm able to see it. That was a wonderful presentation. I was tempted to take notes. It was so nice.
Thanks a lot, Sandhu. Did you see my presentation just now, the second one? Was it visible just now?
Surgery is what we are seeing now.
You're seeing the PowerPoint, right?
Yeah.
Okay, fine. Yeah. So, okay, sorry, I'm sorry about this. I will go to the refractive surgery part, which is from here. Okay, so this talk is going to be on refractive surgery, and we are going to be talking about different kinds, different techniques. Basically, we have cornea-based refractive surgeries and lens-based refractive surgeries. There are two broad types of refractive surgeries that you can do. And these are all the techniques that come under this. You have surface ablation, which can consist of different types. You have the advanced surface ablations, epilastic, LASIK, PRK. You have sub-Bowman's keratomelusis, you have LASIK, you have flex and smile, and then you have the lens-based surgeries like the phakic IOLs and the clear lens extractions or the refractive lens exchanges. So coming to the cornea-based refractive techniques, you can basically, divide these cornea-based refractive techniques into surface ablations, LASIK and RELEX, and that's the trade name, but I'm still using that. When you come to the surface ablation, you have PRK, LASIK, and EpiLASIK, and we'll discuss this a little bit more in detail later. With LASIK, you have the microkeratome-based LASIK and the femtosecond laser LASIK, and all of these that we just discussed here, they all require an excimer laser. So that's what is common to all of these procedures. And then you have the RELEX surgeries, which are basically flex and smile. This is SMILE stands for small incision lenticular extraction. And these two are the all femtosecond laser refractive surgeries, which means that you don't need an excimer laser for these two surgeries. Now, femtosecond is sometimes used with the excimer laser for LASIK, because you can create a flap alone with the femtosecond LASIK and then go on to treat the refractive error with an excimer laser. But in SMILE and flex, the entire refractive error itself is created with the is treated with the femtosecond laser. So now, when you are thinking about what kind of procedure to advise for a particular patient, you should be knowing your procedure. That's most important. You need to know your patient and you need to know your procedure, and you need to kind of, align the patient to which kind of procedure is going to be best for him or her. So there are a lot of things that are specific to individual kinds of procedures. They have specific advantages and disadvantages. We know that LASIK has a flap that's created, and this flap, you need to know that the healing of the flap is never perfect. You can have flap dislocations years after LASIK surgery, and also that the flap does not contribute to the corneal biomechanical strength post surgery. So the flap is just sitting there. It's really not contributing to biomechanical strength. So if your flap is very thick and you've also removed a significant amount or a certain amount of the bed and your residual bed thickness is lower than a certain amount, you can end up with a ectasia, even if your flap is thick, because the flap is really not contributing. So that's what we talked about, the corneal biomechanical effects. In that way, if you look at PRK, it has a better, it leaves a stronger cornea than LASIK, and so does SMILE. So these are advantages of PRK and SMILE. IOP measurement is another thing. So you have a patient who's a glaucoma suspect or something, you do need to know that IOP measurements are altered post refractive surgery, because you have to put in those correction factors. And you saw just now in the Pentacam talk that this Pentacam actually offers you a way by which you can get the corrected IOP if you input the measured IOP. And you have different formulas that you can actually pick and choose from. So another thing you need to know is how refractive surgery affects IOL power calculation, and that's something that you have to be aware about. So you might want to, in an older patient, go in straight for a refractive lens exchange rather than a LASIK, because if you're going to be ending up doing a cataract surgery a few years down the lane, then your IOL power calculation can become more difficult. Though now you have a lot of newer formulas which give you much better accuracy. The other thing that you need to know is almost all of the cornea-based refractive procedures will give you some amount of dry eye because of the corneal nerve transection. It is lower with PRK and with SMILE, but LASIK does give you a significant dry eye, and also the other two also do give you some amount of dry eye. You also have increased, I would not say an increased risk of eye infections, but basically different types of eye infections which present in these patients. So that's something you have to be aware about, that they can be very indolent, long-lasting infections with different atypical microorganisms that can happen post-LASIK. These are just things that you need to know. So if you see a post-LASIK patient with a different kind of an infiltrate, you have to think about different microorganisms. And then you also have to know about the post-LASIK visual quality and abrasions that are created. So now coming to the specific types of refractive surgeries, you have PRK, and PRK basically refers to photorefractive keratectomy, and the epithelium here is removed. And this can be removed with various different types of procedures. You can use just a hockey stick, blunt hockey stick. You can use a dilute alcohol solution and then remove the epithelium once it's loosened up, or you can use an Amoyle's brush, which is basically a polishing brush. Or you can just use the excimer laser itself to go right through the epithelium. And when you do a PRK, you'll see that the first post-operative patient actually has very sharp vision because the epithelium is not yet grown. But then once the epithelium starts to regrow around the post-operative day 3 to 5, the visual acuity decreases, and then there's a gradual improvement over time. So the visual recovery post-PRK is a little more delayed. The patient does have some more pain. It's a little more uncomfortable than the LASIK or the flap procedures, and there is more risk of haze and regression post PRK. So this is a video, just decrease the volume, of PRK, which was basically, this was a PTK PRK procedure, and you can see that there was a scar as well following a corneal ulcer, and basically the epithelium here you can see is removed, and you do a laser ablation, and that's basically this. You also have LASIK, which is laser epithelial keratomyosis, or laser assisted subepithelial keratectomy. And what this does, LASIK and EpiLASIK, the next two procedures that we'll discuss, basically, try to remove some of the disadvantages of PRK and adopt some of the advantages of LASIK. We know that LASIK has a flap on top. It has a wow effect the next day, and the patient is very comfortable. PRK didn't have that. And what these two procedures tried to do was keep an epithelial flap. So instead of having an epithelial cum stromal flap like LASIK has, what they did is basically, instead of removing the epithelium and discarding it, they tried to remove the epithelium in the form of a sheet, kept it aside, and then would replace it back. And the reason for this is that they said that this epithelial sheet would prevent inflammatory mediators as well as inflammatory cells from reaching the corneal stroma, and it would decrease the incidence of haze and regression, and also decrease the incidence of pain post PRK and all these things. But then they found that this was really not so certain that this happened, and people would do epi on LASIK as well as epi off LASIK, where the epithelial flap was actually discarded. EpiLASIK, in LASIK, you would do this, you would make that epithelial flap by using dilute alcohol. In EpiLASIK, you would make this flap using epikeratome. So this is basically similar to the microkeratome. You have a suction ring, and you have this epikeratome, which is a blunt plastic blade, which would remove the epithelium alone in the form of a flap, epithelial flap. And then you could go ahead and do your ablation and replace the epithelial flap, or discard it if you're doing an epi of epilastic. Now, the problem is sometimes this would actually go not just through the epithelium, but also a little bit deeper. And so you could have some of the stroma also removed in a very small area. That would lead on to irregular astigmatism. So these were some of the things that you would have to also take care in case of these procedures. And you would also end up having, we also saw that there was some amount of corneal haze, erosion, and all these kind of complications even in these two procedures. Now, what anyway, I mean, despite the slower visual recovery and the pain that can follow following surface ablation, it is still a procedure that's done. And the reason for this is that you have patients who don't have adequate corneal thickness for LASIK. So as I said earlier, LASIK creates a flap, and that flap has no biomechanical strength at all. It doesn't contribute to biomechanical strength. So if you don't have adequate corneal thickness, you would want to do a flapless procedure, which means you ablate directly on the corneal stroma. It's also better for patients with dry eyes, and also in those patients, those occupations which are exposed to trauma, for example, the army or the police, where they could possibly get a blow to the eye. In these cases, sometimes LASIK flap has been known to dislocate years after. If they don't have that, for example, boxers, professional boxers, and all these patients, PRK may possibly be a better procedure. Also, when you have suspicious topography, because you're not decreasing the biomechanical strength as much, and this is a PRK extra is something that is done in many of these cases, where you can actually strengthen the cornea at the same time with a little bit of cross-linking as well, along with the correction of the refractive error. And patients with larger pupils also, where you can take a larger optic zone if you do PRK. That's another indication for PRK. So, okay, the disadvantages, as we mentioned already: slower visual recovery, haze, regression, and more discomfort. Now, mitomycin C is often used in these patients, and especially for certain indications. For example, if the ablation is more than 3 diopters, or you're treating more than 75, you're treating a larger ablation depth. All these cases, you would also put mitomycin C, and the dose varies depending on what kind of treatment you're going to be doing. That is in an attempt to prevent the haze and the regression from happening. Now, there's another term that you need to know, which is sub-Bowman's keratomelusis. This basically referred to flaps that were created which were less than 160 microns. So originally, flaps that were created for LASIK were really, really thick. They used to be over 200 microns, and those were really thick microns. Now that you have 100 microns and 80 microns and 90 microns possible, all of these become sub-Bowman's keratomelusis. Now, coming to LASIK, you can have, as we just mentioned, it's a procedure where a flap is created, the flap is lifted up, you then do the excimer ablation under the flap, and then you replace the flap. And now you can create these flap with either the microkeratome or with the femtosecond laser. So this is how you do it with the microkeratome blade. So that's the suction ring that's being applied. It applies suction to the cornea. You can see the cornea in between there, and then the Baraka tonometer is being used here to check that the IOP is sufficiently raised. And then this is a microkeratome blade, and you have a forward pass, and then you have a reverse pass, and that basically cuts the flap. Now, this was associated with a lot of problems with the microkeratome, because you could never have an absolute predictability. Now, this is the excimer laser that you're seeing being done. So the flap is lifted up and the excimer laser is being done. Now, the problem is you couldn't have absolute predictability with respect to the thickness that you're going to get. So you would think that you would put in a blade of such and such depth, but actually when you measure post-operatively, you would find that it's not exactly that much. Also, there would be variation in the thickness of the flap from the center to the periphery, and often you would have problems with the microkeratome, such as free cap, or buttonholes, or torn caps, and all these things, suction loss, all these things were pretty common. So obviously the aim was always to move away from microkeratome to something that's more predictable and better in terms of accuracy. So this is a femtosecond laser assisted flap that you're seeing being done. That's the intralaser machine being used. You can have various different kinds of machines. This one is a raster pattern that goes from top to bottom. You have circular patterns which are there in Zeiss. So the flap is lifted up and replaced, and because the flap can have a much better edge profile, the incidence of flap dislocations and flap flap movements post-operatively was also thought to be decreased, as also epithelial ingrowth following femtosecond LASIK. Now, Advantages of LASIK is, as I said, there's a wow effect. The vision is corrected almost immediately, or by the next day, the patient reads 6/6 and is very, very happy. There's very little pain because the flap is right on top of that ablated area, so the recovery is very good, and there's hardly any haze or regression or any of those problems that can happen. And the beauty is you can also make adjustments to these patients years later. Generally, you can do a PRK on top of the flap if you have sufficient thickness, or you can even lift up the flap and do it on the bed if you have sufficient residual bed thickness. Disadvantages, as I mentioned, even with femtosecond laser, you can have flap related complications and you can have dry eyes. So this slide is basically talking about femtosecond LASIK versus keratome, microkeratome LASIK. So as I said, the femtosecond LASIK is bladeless, so there's also a decreased element of fear for the patient and also for the surgeon, I would say. The pressure is much more gentle. You have less vacuum that's created. The subconjunctival hemorrhage is less. It's mostly generally a corneal suction that's created. In microkeratome, it's always a conjunctival suction. You can have more suction loss. You can have greater surgeon choice over flap parameters with femtosecond lasers, increased precision. You can create thinner flaps without the risk of buttonholing or free caps. You can have, as I said, reduced risk of flap complications and also a much more increased safety profile. But now the latest kids on the block are the Smile and the Flex, and the Smile is actually even more advanced than Flex, and this is basically a completely bladeless, flapless and painless laser vision correction. Flex of course has a flap as well, and I'll just show you the difference between these two procedures. Maybe we'll see the video first and then come back to this. This is a Smile, just to make you understand. This is a Smile procedure. You can see the applanation being done. The suction is applied, and that's a femtosecond laser. So you have a base cut, and then you have a cut on top of that, which is a cap cut. So the first cut was a lenticule cut, the second cut was a flap cut, second cut was actually a lenticular side cut, then you have a flap cut, and then you have the incision cut. So there are 4 cuts that happen in this procedure. If you want to see that again, so that's the first lenticular cut, and what you saw right there, that ring over there, is the lenticular side cut. This one which first went across was the lenticular cut, and then you had the lenticular side cut, and now what you're seeing now is more superficial, is more anterior. This is the flap, this is the cap cut, and then finally this one was the incision cut. So now once all that is done, you can see that what you do is basically just dissect on top of the lenticule and below the lenticule. So this dissection is of the cap cut, which is above the lenticule that you're going to remove. And then you have another dissection below the lenticule, which is of the lenticular cut. Once you do both the dissections, so what you're seeing now, second is the lenticular dissection. So now this is dissection below the lenticule, this is lenticular cut. Once that's also done, you'll see that you have dissected out a lenticule here. Sorry, you've dissected out a lenticule and removed it. So that lenticule corresponds to the refractive error of the patient. So you can correct this refractive error beautifully by removing this. This is why it's known as small incision lenticule extraction, because there's a small incision and you're doing a lenticule extraction through this. Now Flex, on the other hand, has a flap, and this is the difference between Smile and Flex. Flex is also fully femtosecond laser surgery. So the cuts are the same. Here you have the side cut, but the only difference is this last cut. So instead of the Smile incision, so everything is the same till here. So you have the lenticular cut, you have the lenticular side cut, you're having the cap cut now, but watch the final part. In Smile, there would have been a small incision here, but in Flex, instead you have a large, cut, just like you have in femtosecond LASIK flaps. So that large cut is what makes Flex different from Smile. So now once you've done that, you can see that you've lifted up this flap, because that was a side cut, the flap side cut. And then you have a lenticule below that. And this lenticule, that's the lenticule. You remove the lenticule, and then you can put the flap back. So Flex really, as far as, things are concerned, it doesn't have too much advantage over flap, because over LASIK, because you're still having all the disadvantages of biomechanical weakening and, more increased number of corneal nerve fibers being cut and all, but that's just to make you understand the procedure. Now, as we said, this is what it is. If you want to see it in cross section, that's the lenticular cut, that's the lenticular side cut, and the flap cut or the cap cut. Now the advantages are it's flapless, so there are no flap related complications in Smile. It's small incision. The biomechanical strength is much more, because here you have uncut tissue extending from edge to edge, so it is also contributing to the biomechanical strength of the cornea. There's less dry eyes, because just simply because In LASIK, you have a large, I'm almost done, Soundari, one moment. In LASIK, you have a large side cut in which all the nerves get cut. But in here, as you see here in LASIK, all these nerves are getting cut, whereas in SMILE, you have only one small cut, so all these nerves are intact. So there's less dry eyes, and biomechanical strength is more. And also, you have a very good safety profile. In terms of advantage to the surgeon, it's a single step procedure, and you have better workflow. And also in terms of advantages for both the patient and the surgeon, there's less dependency on the environment, so it's more predictable also. That comes to the advantages of SMILE. And this is, I think, a very important slide which you can understand. This is a normal cornea where the epithelium is there, and right below that is the strongest part of the corneal stroma, and here is the weakest part posteriorly. In PRK, you're ablating the strongest part of the cornea, but you're having more of the stronger cornea left behind. In LASIK, you're creating a flap in the strongest part of the cornea, and then you're ablating the slightly lesser strong cornea, so that's just the weakest parts of the cornea that are left behind, because the flap is not contributing to anything. In SMILE, you're removing a lenticule from the mid strong part of the cornea, but you have the strongest part there, and you have the the lesser parts, the less strong parts of the cornea still left behind. The lenticule is removed from here, so that's the reason the PRK and SMILE have more biomechanical strength than LASIK. There's really nothing much more to say here other than phakic-IOL. This is basically lens-based refractive surgeries, which can be phakic-IOLs and clear lens extractions or refractive lens exchange. So you can see this is a phakic-IOL being implanted, posterior chamber phakic-IOL. You also have anterior chamber phakic-IOLs. With AC IOLs, AC phakic IOLs, you need to be careful about not damaging the endothelium even in the long term. With posterior chamber phakic IOLs, you need to be careful that your vault is exactly right so that you don't cause cataract. So here is a phakic IOL in place. With the newer versions, you don't need to do a PI. And basically the final one is a refractive lens exchange, which is basically just phaco in a clear lens, and I don't think I need to show that. With that, I'll come to the end of my presentation. Thanks a lot.
Thank you so much, Dr. Susan. It was a wonderful presentation. I think all of them had a good idea about what is pentacam and how to go about it and the refractive surgery. Thank you so much. Now we are going to the last two topics of the day. The complications in phacoemulsification, iris repair, and PDEC. We have none other than Dr. Ashwin Agarwal, who is going to be presenting this. He's one of the best anti-segment surgeon I've ever seen. And any complicated cases in our hospital, we'll be posting it on Dr. Ashwin's name. Over to you, Dr. Ashwin.
Thanks, Dr. Saudri. Thanks, Dr. Divya, for having me. So I'm just going to jump right into it, because I know that all of you guys have been listening to a lot of conversation and a lot of good topics that are taken by absolute star-studded speakers. I'm just going to dive into my topic, and I've just changed it a bit. Instead of complications, I've called it complexities in phacoemulsification, because topics that I've chosen are more for you guys, which actually might help. I have in a financial interest with Zeiss, but not in any of the topics that are for today. The first challenge I think we as surgeons face is one of small pupil, and I think small pupil, lesser said is better, because it's a challenge at any point for any surgeon. What are the difficulties that somebody faces? You have limited view of the rexus. You do have difficulty while you're doing hydrodissection or delineation. When you're doing a chop or you're doing any kind of phacoemulsification of the pieces, it's always going to be a little bit troublesome where the iris comes in the way or something like that keeps happening all along the surgery, and you can finally end up with a prolapsing iris and so many other problems. Blind cortical irrigation and aspiration, and while you're injecting an IOL also, it can get stuck in that small pupil margin. So these are some of the difficulties that you face. What are the solutions that we have in our armamentarium? And that is something that all of us need to know at any point. So the first thing that I probably use is viscodilatation. Second one I would say is intracameral adrenaline. And I think everybody has tried this in their little bit of history. Even if you have just started off, you will know that viscodilatation and adrenaline is the first few things you want to do. Stretching, even though it's recommended, I would say that, you know, in today's world, you have so many other modalities, but stretching is an option. You can try it, and I'll show you also how it's done. But here you go. What I would recommend, if you are stretching, don't do it towards the incision, because the minute you do it towards the incision, you can have iris prolapsing out of that incision. So just a hint there, don't do it anytime there. Mini sphincterotomies, truly means mini sphincterotomies. Just see the size of those sphincterotomies. That's the size you want to get. If you go any larger, you're just going to have a lot of prolapsing or flopping around iris tissue. Pupil expanding devices, you have iris retractors, the Beelers, pupil dilator, the Malvigian ring, the eye ring. There are many. There's even the B-hex ring, which has come up now. And here I'm just showing you a video of how the Beeler pupil dilator works. But this only because I think a lot of you might not have seen how it works. That's all. I think the Malvigian ring is very popular. It's on YouTube, iTube, everywhere. Managing a small pupil, I think once you've got the pupil large enough, then I think you really need to make, one thing you really need to understand is you still need to make a 5 to 5.5 rhexis. You still need to be gentle while you're doing the hydrodissection and delineation. Nucleus chopping is one of an important aspect. So once you chop the nucleus, now understand something, if you look at the diagram on the right, the iris does come a little bit more anterior, and so the space that you feel that you have in the anterior kind of gets disillusioned, and that's something that you really need to understand over here. And sorry about that. The other aspect of small pupil is going to be, once you have done that, you need to aspirate the cortex at the right plane, that is still be at the plane, because the plane completely dissolves once you pull the iris tissue up, especially when you're using iris hooks or anything of that sort. Once the cortical aspiration is done, fill the bag with visco and insert that IOL. These are steps that will be asked in case you're going in for a small pupil. Okay, so here is a viscodilation. I'm going to do a lot of videos because I think some videos in this explain much more than words can. So here are some of the videos that really help explain. How do you do a small pupil without any this thing? This is using just viscodilation. So I'm just using viscoelastic, which is attached to my cannula or to my cystotome over here. And while I'm actually doing the rhexis, along the pupillary margin here, just watch my hand. I'll inject some viscoelastic that expands that pupil just enough for me to actually complete that rhexis. Now, once that is done, you can see the wave. You saw the wave there, and you saw another wave right here. It's not, and you see the pole actually pole up, and that's a good sign that shows that yes, I've got a good wave that's gone. Now, one trick that I use in the small pupil is I really just try to embed as much as I can and just spin that nucleus out into the supracapsular / iris plane. Once it's in the iris plane, I use a very different technique. You probably might not want to try this at home, but I use a technique where I'm going behind the nucleus to kind of chop it. And I'm not using a chopper, I'm using a dialer, which is a much more blunt tip, so it doesn't actually damage the posterior capsule in any case. Once this is done, I'm doing again viscodilation to kind of assess and do an irrigation aspiration. Remember, the more you manipulate the iris, the more it will shut down and it will have its own dilatation issues. Then you have the intraocular lens implantation. Once the intraocular lens is implanted, I used to use a bubble. Nowadays, I try not to use a bubble anymore at the end of the case. Here I'm showing you now a case of an iris hook and how it's implanted. So I make 4 incisions, side port entries, and just make sure that the iris hook goes under the iris tissue, but make sure that also if you have done a rhexis already, then it's a little tricky because you have to miss the rhexis margin. So in this case, I'm trying to show you how to use an iris hook and how beautiful it becomes once you've actually implanted an iris hook. Because now it becomes completely easy. You really don't have to do any blind procedure. You can visualize what you're doing. And if it is running through the periphery, you really can hold it and bring it back using the Brian Little technique. And that's called the capsule tear out technique. Once we're done with this, you can see that you can see all the edges of that anterior capsular rim, and you can see the cortex that is hanging around there. And once you grab that cortex, you can actually just easily pull it out. Now, watch very carefully here. There is a small piece of tissue that's lying right under the iris hook. That tissue is a nucleus piece. That's in the superior side. If you see, there's a very clear tissue, nuclear piece that's hanging, or it's stuck between the iris hook and the iris as well as the cornea. In between those 3, that junction, it's stuck there. You really need to be able to go and capture that out. Once that is done, you're able to implant a lens. Now let's talk about the eye ring. Eye ring is another trick that you can use. I'm just going to take you directly to it. Once you have placed the eye ring inside, all you have to do is place it on in the pupillary margin. Once you've placed it on the pupillary margin, the fourth one is always a little more stretchy, just like the Malugin ring, but this is a little more less flexible. The Malugin ring is a little more flexible. And once you're done with that, you can actually see the end of the case, how you take it out. It's all foldable, so it just comes back into the same port. These are some of the tricks I wanted to show you for small pupil. I'm going to take you to posterior polar cataract now. In posterior polar, this is the second challenge I thought people do face in their armamentarium, and they should know how to deal with this. You always have, it could be masking a posterior capsule compromise or an opening. And a very high chance of PCR is something that is very highly associated with the posterior polar cataract. These are some of the notes I felt were important. If you guys want to take a snapshot, go right ahead and take a snapshot of this. I'm not going to take you through this because I think videos are more important in these cases to see what actually needs to be done, and I'll take you through those points which I'm doing. So here's video number 1 where I'm doing a posterior polar cataract, and you see it's a very bad looking, ugly looking posterior polar. So first thing first, I make a very small incision. I don't enter fully because I want that viscoelastic to be inside and maintaining my chamber at all times while I'm making my rhexis. Make a smaller but not too small a rhexis, because if in case this does have a posterior polar opening, you want to be able to place a sulcus lens. These are called visco pockets that I'm implanting into the cortical space. And now a hydro delineation that actually helps me get a golden ring sign. Now, once this is done, this being a very, very soft nucleus, and ideally in a very young patient, you will get a soft nucleus and a thick polar end. So you need to be really careful at this edge, not to aspirate too fast. At the same time, now push some viscoelastic before you pull your probe out. So viscoinflation before you put your probe out is a very important step. Once you're done with that, again, you go ahead with irrigation aspiration. And just in interest of time, I'm going to go ahead again, only show you before I pull my probe out again, irrigation aspiration probe, I'm going to push some viscoelastic inside the eye so that the eye does not collapse or does not become shallow again. And same thing follows. Once I'm done with my IOL entry, usually nothing ever happens after this. So we're pretty much good to go. I'm going to show you another case where it does not go so well, but let's see what happens. So again, I'm going to, in interest of time, I'm going to go a little faster. I'm going to do my chops. I've done the same visco pockets. I've done the same hydrodelineation. I've done the same cortical embed and pull the cortex or nuclear embed and pull the nucleus into the anterior chamber. Once it's done that, I'm now left with cortex. Now I'm doing my irrigation aspiration, and if you can see here very clearly, there's already a PCR opening over there. But this posterior capsular opening is not associated with any vitreous loss or vitreous prolapse. That's a good sign, and I'm just using that to my advantage. I'm using that this case has not yet gone in for any vitreous prolapse here. And again, make sure that you always have viscoelastic inside the eye. See this is the posterior capsule, the opening, and usually you will have this in an elongated manner. Now I'm putting a 3-piece lens because in any complex scenario, I always put in a 3-piece lens. I can glue it at any point later on if in case it does turn bad. I'm placing this in the sulcus right now. Because I find it always easier to place it in the sulcus. Plus, it's the right thing to do in these cases. In case you have, you can go ahead and place in the bag, provided that you are confident about going ahead and placing an intraocular lens in the bag, as well as it should be in the opposite direction of that opening. Once you're done with the sulcus placement in these cases, you can go ahead and close the case. It reacts absolutely fine the next day morning. The last challenge which I feel is very important to talk about is posterior capsular rupture, and we all face this. This is one of the dreadest, most complications that we all face in this thing. It can happen for many reasons, and it can happen at many times. That's the biggest issue, and that's where the plan A and plan B all goes kaput when we don't know when it happens. So here it is. These are some of the complications if you just leave the case as it is in posterior capsular. rupture. So I'm just going to take you a little bit back of vitreous prolapse. When you have a posterior capsular rupture, you have something called as vitreous prolapse. Let's understand this from two aspects. You can have a central posterior capsular rupture, or you can have a rupture at the zonular level where the zonules are broken and you have vitreous coming into the anterior chamber from the periphery. So peripheral vitreous prolapse and central vitreous prolapse. Let's go and talk about central vitreous prolapse. Let's divide it into 1, 2, 3, 4. 1 outside, 2 in anterior chamber, 3 at the level of the opening, and 4 in the vitreous body. Let's see what happens when you treat this from a limbal route. If you treat vitreous prolapse or any PCR from a limbal route, as soon as you cut the vitreous in the anterior chamber, more vitreous comes out, and see what happened to the opening. The opening now has opened up far furthermore. So how should you treat it, and how ideally it's supposed to be treated is from a pars plana approach, and that's what I wanted to talk about here. So once you have vitreous prolapsing, you first go in the pars plana approach and disconnect the two cords first. Once you've disconnected, then you can go ahead and anterior vitrectomy and do an anterior removal of the vitreous. That way the hole does not increase in size and you can actually place that lens in the sulcus. Now, the same thing let's talk about in the peripheral. In the peripheral, same 1, 2, 3, 4, nothing changes, but let's take what happens in this. It comes from the zonular side, goes outside. Once you disconnect this, or if you do anterior vitrectomy from the limbal route, you will have more and more vitreous coming into the anterior chamber. If you go through the pars plana route, you will be helping in disconnecting the two cords. That is, the whole vitreous acts like a jelly. It's one big jelly which you have to disconnect the cords and then take out the rest. And that's one of the most important factors. If you guys can understand that part over here, I think that's a huge win for the whole education system that we can try and provide. So let's see what happens here. Let's see this in an actual case. Let me take you through an actual case, because this is a case where you have a big, large central PCR. And I'm saying large because it's gone way beyond me to actually provide any kind of sight to what needs to happen. So I'm first putting in a trocar that is posterior, so that infusion is inside the eye. Once infusion is there, I'm just doing a little bit of anterior vitrectomy to ensure that nothing is in my port. And I'm leaving that iris tissue purposely because that helps me, that behaves like a opening, or it behaves like an iris hook. What I'm using my vitrector is now using a pars plana approach. I'm going in along with vitrectomy. I'm also aspirating the cortex that is actually left behind. So I'm using 3 ports, that is the anterior limbal route, I'm using the pars plana route, and the main incision. So I'm using all the 3 ports to ensure that I'm able to remove all the vitreous as well as all the cortex from these posterior capsular rupture. Now I'm assessing the sulcus. Now, once I see that there is a good enough sulcus, it's very important to know how to place a sulcus lens. Keep it sidewards and ensure that the leading haptic goes into the sulcus. Now place a rod under the IOL so that it doesn't tilt or move into the opposite, and drop it rather than dial it. I don't like dialing these lenses, because when you dial, you can snag somewhere and it can pull one of the capsular tissue, and it can pull the zonules apart. So that's the small tricks that I can say for sulcus placement. This is my talk on complexities of phacoemulsification. I'm going to now share with you the presentation on, I'm not sure, can you guys see my screen? Not yet. Can you see my screen, guys?
Yeah, we can see.
We can see.
We can see.
I'm going to talk to you about iris repair. I think the function of the iris is to behave like the shutter of a camera. And that's the function that we want to retain. And that's the function that helps human beings actually see clearer as well as dimmer when needed, more brighter when needed. So that's the function that we want to retain in this. And sometimes what happens is you lose that function when you have iris tissue like this, when a lot of light enters the eye. So some of the great innovations in the past, and I'm going to take you through a video series of sorts. The McCannell's suture. What we do in a McCannell suture is basically this. We pass a 9O or a 10O proline suture from one side, and watch this, what I'm doing. This is a coloboma case, and I'm taking forceps to hold the iris, pass the suture from one side to the other side of the iris and bring it all the way out. Once it's out, I take a loop from one corner and I take the same loop from the other corner, bring it out, and now chop in the middle of this loop. So I don't need the whole loop actually. I need only the two ends that tie together and become like a shoelace. Now I'm actually tying these two intracamerally. So I'm taking this back into, this is a modified mecanals. Earlier they used to do it in a different way, but this is a modified version of the same, where I'm actually taking it 3 throws and tying it down. You get a roundish pupil. Now bring out those same two ends again and tie them once again. You can do 3-2-2, 3-1-1, or 3-2. You can decide as to number of times that you want to throw this, and the manipulation is a little bit more in these cases, especially because you're going intracamerally. But it gives you a beautifully round pupil, and this is the day one post-op of the same. Let's take you through another series of where I'm showing you a Seepsers, or let's say a modified Seepsers knot. But a modified Seepsers knot for iris or pupil repair would involve two ends. I've made 2 holes and 2 entries, but one I'm passing through a needle, or that is a tenoprolene suture, and the other end I'm railroading it through a bevel open needle and bringing it out. Now I take a loop from the one end and bring it out through the other end. Now the loop, I just pass it 3 times and tie it down. Now 2 times. So it's a 3-2-1 or 3-1-1 depending on what you want to choose. And this is again gives you a really good round pupil. The advantage over here is you use only one side. You don't have to bring it out or any of that sort. Now the third I would like to show you is it's a longer procedure, but it gives you beautiful results. It's called cerclage, and I'm thankful to Steve to pass on this video to me, because I don't do this procedure personally, but I think it's very important that you have 4 holes in this diagonally opposite each other and pass from one side to the other. So you bring it out and now again go in through that same round and pass it like as a purse string suture. You're passing it through a purse string approach 3 to 4 times from one end to the other. And once you brought it out on both the sides, you just have to tie them together and look at it come all the way. So like a pupil coming down, it brings it all into place. You might sometimes have a gap or a gaping wound on one of the edges. You just have to do another pupilloplasty at that edge. And this is some of the post-operative views that you get after the cerclage, after a good cerclage. It can be tedious. There's a long learning curve to this, I have to admit. And that is one of the few reasons that this procedure has not become very, very popular, but it has great results nonetheless. Single pass 4 throw. And
let's understand how this proceeds.
Yeah, single pass 4 throw is the newest kid on the block, but I'll just explain this in an animation, and that helps a lot. So you have a proximal iris and you have a distal iris. From the distal iris end, you make a stab entry. Proximal iris, no stab entry. Distal iris, you have an incision. So again, look at it here. Proximal iris, you just go in with a tenoprolene or a ninoprolene suture all the way through proximal incision, proximal iris. From the distal incision, take a 27 gauge needle and pass it through the distal iris and railroad that whole suture out. Watch again, the tenoprolene is going through the 27 gauge and coming out. Now let's break this down a little bit to understand the suture trail, as I call it, the suture trail. So the suture trail exists of 5 parts. Let's divide this a little bit more. External to proximal incision, the proximal incision to proximal iris, the proximal iris to distal iris, the distal iris to distal incision, and the distal incision to external. So these are the 5 parts that we want to talk about. Why is it important? Because the next step is taking the loop. I'm taking the loop from part 2 and bringing it out of the distal incision. I'm taking the loop out and bringing it out. Now I cut part 5 and throw part 5 into the loop 4 times. Remember, it's one pass that I've gone through the iris and I've thrown it 4 times into the loop. That's it. Single pass, 4 throw pupilloplasty. And that's about it. I just pull these two apart outside externally, and that gives me a helical pattern on the knot that I really want to attain. And I can do this 2 times the speed at which I can do any of the other procedures. And that's one of the reasons why this has become very popular. Now, one of the questions asked to me is, does this not come out, and does it disconnect at any point of time? Till now, we've done many, many cases, and I think a lot of surgeons across the world have done many cases. They have not experienced this not coming off. But yes, if you have not tied it tight, it can come off. So you need to just tie it like a shoelace. We are tying it tight, and then you're good to go. But you get a really round pupil, same as you would in the other cases. Let's go ahead and talk about iridodialysis repair, because that also comes under iris repair. We have Hoffman's pocket technique. Let's understand this procedure first. So in the Hoffman's pocket technique, this was discovered and invented by Richard Hoffman himself. What we're doing is basically making a scleral pocket towards the fornix, not towards the cornea. Now we're making a scleral entry towards the fornix, marked it, and just bring out the suture while taking the iris root. So you take the iris root and bring out the suture with a double-ended, double-armed suture. And once you're done with this, you take that end of out through the pocket out and tie it 3-2-2 or 3-2-1 or 3-1-1. But the trick over here is, again, watch, I pass double-armed suture all the way through, bring it out through the pocket. So like you're putting your hand in your sleeve, in your shirt pocket, and bringing out a pen, the same way you would bring out the suture in this, and now cut it. And once you tie it down, you cut it and push that knot back into the pocket. So the knot gets hidden, your iris gets back into shape. And this is one of the big advantages of doing this technique, where it's slick, it's neat, and there's not much, it's very clear. Now, hangback technique is a very important technique to know, where you're doing the same thing. Where you're doing is double-armed suture, only thing through a ridge. You're using a ridge to bring out that suture, and you're going to pass this the other end of the needle. Make sure that your cornea does not, the lamellar part of the cornea does not get involved. Once you bring out both the ends of the suture, pull it back. You'll watch this pupil actually come a little bit towards that side. That's okay, but you want that iris tissue hanging back. That's the most important step over here. Once you have that iris back, this is your hang back technique. I'm not going to show you the rest of the case because that's a glue dial as well. So that's a lot more. Another new technique that thanks to Yamane that came about is the flange technique, where we're using a 6-O-proline suture, burning it a little bit with a low temp cautery, ensuring that we take a 27 gauge needle, pass that 6-O-proline through the free end of it, pass it through and bring it all the way out. The bulb end of it is actually the one which is, now you'll watch it here, the bulb end of it is actually pulled back, and that you cut this and now flange it back down so that this brings to you the knot, and that's not going to release from both the sides, giving you a flanged look of how you can actually treat an iridodialysis repair through a flange technique. The last but not the least, and probably one of my favorites, is the sewing machine technique. It was discovered by Ravi Kumar, I think, from Bangalore. But his technique has really won hearts across the world, and is very, very nice in its own way. By making a ridge at the site of the iridodialysis, the tenoproline suture is passed through a 27 gauge needle. And this needle now becomes your apparatus. We don't really need the tenoproline, we just need the suture. What we're doing is basically taking that needle and pulling it all the way out like a sewing machine. Now you don't come out all the way, go back into the intracameral space and take a new spot and come out. So you get a loop. Hold the loop, come back into the intracameral space and go back out again using the iris and the sclera as your pivot points. So this is what you get at the end of it. You get one free end and 2 loops. Cut between the loops and tie 1 to 2, 3 to 4. Again, cut between the loops and tie 1 to 2, tie it down under the ridge so that the knot gets hidden. Once the knot gets hidden, you're good to go. When you have a pupil that has been formed again, and you have an iris that has gone back to its root. And that's the biggest advantage that you get with this technique. And it's so simple and easy to use once you've started to do this technique. This is the end of the case, which I wanted to explain to you guys. From the iris repair perspective, I would love to take questions, but I think Soundari might not like that. If we want to finish all the topics. We have one last topic.
Questions in the chat box.
Okay, we will take that as well.
Yeah.
I'm going to finish off my PDEC technique as well. So I just thought it's easier to explain why PDEC is my procedure of choice. I think you get a stronger graft, the increased endothelial count, and I'll come to why these are important. Because of the younger graft, of course, you get a younger graft, you get an endothelial count which is high. You get a thin graft, a tear resistant one, and one which is donor age independent. When I say that, I mean to compare it to the DMEC, where the minimum age you need to do a DMEC with is a 50-year-old cornea, whereas the minimum age for a PDEC would be a 1-year-old cornea. And these are some of the reasons. Anyways, coming back to the point, PDEC is the layer, pre-desmase is the layer just above the desmase that was discovered by Harminder Dua. Now let's explain how do you graft, how do you get the graft out. A 30 gauge needle is taken, and you pass this needle through into the intrastromal space. And once you're done with this, you can actually, all you have to do is pass a knife through the bubble and put some trypan blue inside. And this is all done right now at iBanks as well. Once this is passed through the, we're doing it manually.
We can't see your screen.
Oh, I'm so sorry.
Yeah, we can't see your screen.
Oh, man, I was so sorry about this. Can you see my screen now?
Yeah, now we can.
Yes.
So sorry.
So
okay, so this is one of the reasons why PDEC is my procedure of choice. But I'll come back to this point. Here you have the pre-desmase layer, which is just above the desmase membrane. And just to explain, just to go back a little bit, it was discovered by Harminder Dua. It has a diameter of 9 to 10 millimeters and a thickness of 25 microns. And it's present between, it's probably the last layer of the stroma that becomes the pre-desmase layer. Let's see how to harvest this. Now watch this. I'm taking a 27 gauge needle, or nowadays 30 gauge as well. Pass it through the intrastromal space. Once the intrastromal pressure is increased to a particular level, you can actually go ahead and pass a knife through that bubble, and now put some trypan blue inside the bubble, which stains it from inside. Now you can watch the stain and help yourself to cut this all around you. This is a more manual technique. In the iBanks now, they use a lot more automated techniques by using a trephine, which gets a smoother edge at the edges. And this is now placed in the cortisol or the NK medium, which is given. How does this bubble form? And this is something that you guys probably need to know. The type 1, type 2, and type 3 bubble. The type 1 bubble is the PDEC bubble. Let's just make it very simple. Type 1 bubble is the PDEC bubble. The type 2 bubble.
Ashwin, slides are not moving now. Or are you not moving the slides?
I am moving.
Yeah, now it is moving.
Okay.
Now it is moving. Yeah.
Is it better?
Perfect. Yeah, perfect.
Did it move?
Yeah, PDEC graft preparation. It is on PDEC graft preparation. Okay.
No, I'm on bubble formation.
Yeah, bubble formation.
Perfect. Okay. So the type 1 bubble is the PDEC graft, which moves from a center. Whenever you inject air into the cornea from this place, if the bubble moves from center to periphery, it's a type 1 bubble or a PDEC bubble. If the air moves from a periphery to the center, this is a type 2 bubble or a DMEC bubble. And this is the easiest way that you can understand what bubble is. Why this is important is because the thickness is different, the tensile strength is different, and the popping pressure is different. When I say popping pressure, if you look at the left one, the popping pressure of the type 1 bubble is about 766 mm.
Ashwin, again, the slide needs to move. Yeah. Now it is okay.
Fine.
Oh, but I didn't move the slide.
No, this is okay.
Okay.
Yeah, perfectly all right.
Okay. Can you see PDEC layers redefined?
We have type 1, type 2, and type 3 bubbles.
No, it's not moving. That means my slides are not moving. Just one second. Just one second. I'm just going to stop the share. A few seconds. Sharing is paused. Bring your shared window in front. I don't know why this is
Now
saying.
we see corneal layers redefined.
Yeah, but it's saying my sharing is.
But for
When
us, it
I'm
is
doing
saying
it,
you are viewing Ashwin's screen.
yeah, but when I'm
Now you go to the next.
one second, it's not allowing me to share. No, it's going to the next for me, but it's not going for you guys.
No, for us, it's not going.
Yeah, it's not going for you. I'm just going to close my presentation and open it again, if that's okay with you. I think that might help. But I'll happy to take some questions, Soundari, if meanwhile, while
So
I'm
there was
opening.
one question on, do you want to put air bubble for all cases? Do you put air bubble? Do you do PI for your PDEX? Because for DMEC we do PI, but DSEC it's a case to case basis.
Yeah, on case to case basis, I do, but predominantly I do only if there is a. One second. Just tell me if my screen shares. Just one second. I'm so sorry about this. I know
Yeah,
it's sharing now, but just tell me now.
it is sharing now. Corneal layers redefined.
Okay,
PDEX
perfect.
graph preparation, yes.
Okay, now it's good.
Yeah, it's okay. It's moving. The movie is moving.
Okay,
Perfect.
perfect. So I'm just going to go back into the type 1, type 2. Or do you want me to answer that question of PI? I'll answer the
You can
PI.
answer that later.
I do PIs if need be, especially if there is a case where there's a phakic this thing, then I will do a PI. If there's a glue dial case, then I don't usually do a PI because it's anyways all open. So these are some of the reasons I would do and not do. Now coming back to type 1, type 2. Okay, so let's just take you through this. So here you have, what does the popping pressure mean? Now look at this. I'm injecting more and more air into this bubble. And as I grow and inject, it will not cross 10 millimeters. This is what I've tried to see many, many times. It will rather burst than cross 10 millimeters, versus a type 2 bubble or a DMEC bubble will go all the way to the periphery. And in fact, I'll go from one periphery to the other and then pop. And it will pop at a very, very minimal of 26 mm. This is the biggest difference that I have seen in between these two popping pressures of the two bubbles. Uh, PDEC graph posting is donor age independent. These are 9-month and 1-year-old donors. Let's understand a little bit of the recipient now. How do you actually, what do I do differently? And I'll show you exactly what I do. 3 different things in recipient donor preparation. Recipient preparation, how do you prepare it? I first remove all this epithelial all the epithelial tissue on top. Once that is done, I use a Procar AC maintainer in all my PDEC cases because I want continuous infusion of air at all times. Once I have continuous infusion of air, I do make 2 openings, both one superior temporal and nasal. Once I have that, I have air, Procar AC maintainer, and on the side, which Susan taught us very nicely, was a endo illuminator. An illuminator gives me a tangential light reflection that is so very important to see all the tissues of the margins of this layer come out. More important is if any small tags that are left behind, I'm able to see it with that little bit of light or a tangential light that is coming in. That is the most. Look at this small tag, which I would not be able to see otherwise if not for for the light, for the endo illuminator. So the air gives me that view, the light gives me the reflection, and my forceps give me all the help I need to remove that DMEC or the desmus membrane from the recipient graft. Now once I switch off the air pump, I inject some fluid inside through the side port. Now important part over here is to removal of the sponge tip and the spring from the injector system. Now that spring is very important to understand. Once you have loaded the graft in, why the spring removal is important is so that this graft now does not go springing back. Now it's loaded and kept. I can push it when I want. Watch here. I keep a very, very shallow chamber here. Very important to keep a shallow chamber when you're injecting the graft, because the graft is going to look for a spot for least resistance. And that might be outside if it's too tight or too taut inside. Now, the advantage of doing PDEC is I can do this with the PDEC tissue, which I couldn't do. Now I have air infused inside, which is holding my graft on top. And I'm also using reverse Sinskey hooks to kind of iron out the edges, which if I do it on a DMEC tissue, it will actually tear and it will come out like a tin foil on a dairy milk. I don't know how many of you eat dairy milk, but yes, that's how it actually turns out. It tears out. Once that is done, I have my graft in place. I put my sutures. This is day 1 post-op. Let's watch a 3 weeks post-op of the same patient. This is 45 days, and here or post-op of the same patient, which I thought was pretty remarkable, and we've got some really good results. But here's the comparison which I thought was very important for everybody in this who's viewing this webinar should have. Of all the 3 techniques, I think all of them have merits to themselves, and I probably would not be able to say that you have to use only one over the other. But yes, PDEC is the first choice that I would say. If my PDEC tissue or my bubble does not come right, I would definitely go ahead with the DMEC. And in certain cases, I think Dr. Namrata is an expert in DSEC, and she can definitely give some tips and boost the DSEC bunch as well, because it's definitely a lot easier to do a DSEC, and the learning curve is definitely much lesser than a DSEC. Here are some of the tips and tricks. The trocar AC maintainer, as I spoke about, how do you do the desmetorexis in these tissues? Air, the trocar AC maintainer, the air, as well as the light endoilluminator. So you can see the margins, you can see all of the tissue come together in the center and pull it out with using a forceps. Any tags left behind can be held and seen before you remove. So everything in ophthalmology surgery is basically what you can visualize. Now, another trick is about the endoilluminator, which I told you. See the light, how it actually helps us even realize which way the graft is folded. Here is a fold unfold technique which I use, where you basically fold it and then it automatically unfolds on its own, which is what I want to use. The double infusion technique is a little more complex. Let's not try and explain that today, but removing the trocar ACM is probably the most important step in PDEC, because as soon as you remove it, sometimes these things collapse. So actually implanting the trocar ACM antenna also becomes important. You have to use a valvular fashion when you go in to use this trocar ACM antenna. These are some of the tricks that I wanted to show you guys, and thank you very much. You can obviously see.
So much, Dr. Ashwin. It was an excellent presentation. After seeing your videos, I think anybody will become a confident surgeon. Thank you so much. So all of you, I hope you enjoyed the day 1 program of the Kalpavriksha, which covered cornea and cataract. Tomorrow we'll meet you again at 6. We'll be covering up orbit, oculoplasty, and uvea tomorrow. See you at 6 tomorrow. Good night.
Good night, guys. Thank you.
Thank you so much. Yeah.
We have achieved 1 million lens implants. We are STAR, and infinity is the next milestone.